One fine day she came, there is a patient of TKR, हमें anterior satel block दिया, हाँ? Anterior satel block? No, sciatic nerve the posterior है ना? हाँ, posterior है, हम anterior से दिए, femoral artery, हाँ, nothing happened to femoral artery. Anterior sciatic was, say, have you thought about, let's be very frank about all of us here. But that's a need. That's a need. So, before coming here, I had 1 hour discussion with Dr. Sandeep Diwan, and still yesterday she was also seeing my PPT, because she has to also get convinced, she should know there is something which is learnable here. It's not only my perspective, so that which will help all the people sitting in this hall. So, thank you, Veena, for giving me a wonderful opportunity to share something new. So, click money. It's okay. Something new in this. So, I use the theme of old film roles because I come from theatres where I used to see. Initially, there used to be reel coming, afterwards there will be scratches, after that the movie used to start. So, I use that theme for this talk. So, thank you very much for giving this thing, and I will try to answer your question to the capacity what I know. I am not an expert. Let me be very frank. I also learned by reading rigorously for 3 months, 3 to 4 months, daily sitting in my chamber and reading something. So, I'll be able to answer your question. Thank you.
Thank you, Dr. Manvikar, for the beautiful narration of the facial planes and the importance of regional anesthesia. And we all will be teaching the students what is the attachment of the fascia, thoracolumbar fascia, and relation of the nerves with the fascia, and the extent of the local anesthetics extending cranially and caudally. So it was a beautiful narration. Any questions from the audience?
Any questions from seniors?
Because like tissues like muscle and nerves, their threshold is so low that minimal of changes in those, whatever you call.
Sir,
so
usually
probably in the fascia, I think the threshold is
maybe,
there,
sir, maybe. Threshold may be low. Maybe the threshold of very good concept, sir. The threshold of the nerve below down may be low, or there may be some other dynamics of fascia which are not allowed the spread to go down before infraumbilically. In type you are talking, no, sir?
Even the nerve endings there, the threshold is very low, so that, I mean, it is in fact not low, it's very high. That's why it requires more of a higher dose of anesthetic.
Sir, the literature says they have used maximum 30 to 35 ml.
No, that is in, I mean, quantity wise, but the strength of that medicine. Like
maybe.
So.
Maybe.
Okay, sir. Thank you, sir.
Thank you, sir. Yes, sir. Sir, please sit down, sir. Sit down and ask. You don't need to stand up and ask.
Excellent presentation, sir.
Thank you, sir.
And you have made us to think out of the box. And you emphasize the importance of learning ultrasound by the anatomist. Being a doctor, you can get an ultrasound machine into the department, and as long as there is no patient involvement or practicing involvement, then I don't think there is any legal issues. Because
sir, finish your question, sir. I'll answer.
whenever also you can do the ultrasound. And in foreign countries, MRI, CT, ultrasound, cadaveric, is permitted. They are doing it. Only in India, I don't think so far, even for forensic medicine, they are going to establish All India Institute of Medical Sciences. Exclusively for, autopsy purposes in forensic medicine department. Otherwise, nowhere in India it is permitted. So dead bodies are not allowed to be placed in the CT or MRI. In some of the medical colleges already the ultrasound is existing. In KGMU, their collaboration
they have, sir,
with the anesthesia department, pain management department, others. So similarly, the other medical colleges can establish. It's a cost of, I think, 15 to 20 lakhs.
Yeah, yeah.
Or even sometimes the old machines which are out of work for radiology or obstetric gynecology, you can take it from them for training. So, I mean, you have made us to think that importance of ultrasound and radiological anatomy as a whole is good for anatomist. Thank you very much, sir.
Thank you, sir. See, I'll answer your question now, sir. In India, there is something called the PCPNDT Act. Please sit down, sir. Because of sex determination by the ultrasound, the administration doesn't see whether you are anatomy department or whether you are forensic. You are if anatomy department, they will say you may be doing sex determination without knowing to others. They will think that every opponent is a chore. But for that, there are two registers are supposed to maintain. Form F, there is a Form F, and there is one more declaration, which I used to do when I was heading the genetic division in our department. Every fourth, we used to send a report saying that how many analyses we have done, how many ultrasounds we have done, and we used to declare that we don't have ultrasound machine in our lab, we don't do genetic counseling, we don't do prenatal. That's the rule. That if we religiously follow, there should be not an issue at all. But the register has to be maintained, and they will come and check. They will come and check now and then. They may come and check surprisingly also.
Yes.
Your register should be ready, and you will tell you are using this for research purposes. And we will ask for a good machine, sir. Why ask for a junk machine? Sir, they will get. We will tell them, you get it. This is important.
Yes, sir.
Sir, if you ask for a new machine, we will get an old machine. Thank you very much, sir.
Manvikar, sir, last one thing.
Sure, sir.
It is one of the best sessions I ever attended in any conference.
Thank you so much, sir. Thank you so much.
All the credit goes to you to translate the anatomy into clinical applications. Thank Veena for selecting such faculty for presentation. Regarding PNDT, it is a must. Whether you do on cadaver or whatever, PNDT approval is a must. And always go for best machine, not the old machine. For cadaver, you need best resolution machine. And you can get it for the workshop for a few days and you can do that. Wonderfully done, sir.
Thank you, sir.
The Sandeep Diwan is a legend. So
he's a legend, he's a good friend of mine.
And is willing to come to your colleges and do that workshop also.
In fact, he took your name also.
Yes, sir. We were in discussion, but it did not materialize. Now I feel definitely we'll go for Sandeep. Wonderfully done, sir. I feel happy that now attended this conference. Manvikar, sir, hats off.
Thank you, sir. Thank you so much. Sir, use it, sir. Get it back. We had in our department because we actually tried on in the hands and all those. Sir, all ultrasound belongs to anatomy, belongs to us. Let's think of that. It is not their domain, it is our domain. Diagnosing diseases is a domain. Ultrasound, radiology, anatomy, it belongs to us. I gave the analogy, sir, because the chair is empty, we are not sitting, somebody else is sitting. Simple. Aap jagah but nobody will come and sit there. And they will think you as an expert only. Yeah. Thank you so much. Thank you,
madam. Thank you, Dr. Purushottam Rao Manvikar, sir, for that insightful and enriching oration. Your clear anatomical correlation with clinical practice have certainly left us with better informed and inspired. May I request distinguished chairperson and Dr. Veena Kulkarni madam to kindly give away the token of gratitude to Dr. Purushottam Rao Manvikar, sir.
May I request Dr. Suresh Manguti, sir, to kindly join.
We also express our heartfelt appreciation to our esteemed chairpersons, Dr. Shashikala Ramchandra Londe Madam and Dr. Sharda B. Mensinkai Madam, for their dignified presence and for conducting a session with exceptional grace and scholarly discernment. May I request Professor Dr. Veena Kulkarni Madam to kindly give away the token of appreciation to the respected chairpersons.
Thank you, ma'am. With the conclusion of this enlightening session, we now invite your attention to the next distinguished lecture in today's academic program, Sri G. Dayanand Oration Lecture, instituted by Sri G. Dayanand, Saptagiri Group of Institutions, Bengaluru. Our next session features an oration by a dynamic academician and a researcher in the field of translational neuroanatomy. We are honored to welcome Dr. Rupa Ravindranath Madam, Professor, Department of Anatomy, Chandrama Dayanand Sagar Institute of Medical Sciences, Medical Education and Research, Dayanand Sagar University, Kanakapura. She will be delivering a lecture on translational research, clinical neuromodulatory effects of deep brain stimulation in disorders of consciousness. To chair this intellectually rich session, may I now invite Dr. G.M. Mahesh Sir, Professor, Basaveshwar Medical College and Hospital, and Dr. Uday N. Kudalkar Sir, Professor, Goa Medical College. I kindly request the chairpersons to take the dais and guide us through the proceedings. I request the chairpersons to also kindly introduce the guest speaker. May I invite Dr. Rupa Ravindranath Madam.
Dr. Rupa Ravindranath is currently working as an additional professor in the Dayanand Sagar Medical College, Bangalore. But from long 33 years of service or more than that she has got. Earlier she was a staff or working teacher, professor in the St. John's Medical College, working also in the genetics department as I know, because I sent my postgraduate students to her for training for 1 month posting. So she is a good anatomist, very good, very fantastic anatomist. She guided numerous postgraduate doctoral students' topics ranging from the coronary artery variations and neuroplasty studies on rat brain also, animals also she has done very lot of works. Dr. Ravindranath has an impressive body of research with over 65 publications, national and international indexed journals she has published, and also working with the Center of the Disease Control, Atlanta, involving studies on diabetes mellitus. Her preferential professional affiliations, life membership of the Anatomical Society of India, Karnataka Anatomists, and Anatomists of Indian Human Genetics also. With a strong foundation of the research, education, and academic administration, Dr. Rupa Ravindranath continues to contribute meaningfully to the field of the medical science and to the training of the next generation of the healthcare professions. Thank you. Welcome you for...
Thank you very much, sir. So this is my privilege, and it's my proud privilege to be amidst this august audience. Thank you to the organizers, and special thanks to Dr. Ashwini for asking me to, choosing me to deliver this lecture, this oration. So I have chosen the topic clinical neuromodulatory effects of deep brain stimulation in disorders of consciousness. I was pleasantly surprised to know that the chairperson has worked for 4 years in neurosurgery. So when he was sitting beside me, so he may be able to answer more than I can here. Yeah, I've chosen this because just to fit the theme, tradition and translational research. And really my part in translational research was with my two students who completed their PhD in 2 different areas. And that was not on deep brain stimulation. That was on ECS, that is equivalent to the shock treatment in the psychiatric patients. What is called in animals is ECS. So instead of ECT in adults, it's called ECS in animals. But when I went to present in a conference way back in 2012 on amygdala, already there were newer things happening, and that was deep brain stimulation. But by the end of my preparation for this lecture, I realized that deep brain stimulation is left far behind. Now it is adaptive deep brain stimulation, if anything at all. But my area of interest is not this is just a mask, because I want to talk on what is normal, and that is consciousness, as you will see in some slides later. Yeah, so as anatomists, we are really bridging the gap between, in translational research, because, what we do is going to be translated to the clinical field. And the next 3 slides will talk on, I can't take the mic and start talking on consciousness. So I have to put a mask and say that, well, we're talking on disorders of consciousness. And so just the next 3 slides will actually show my area of interest, which is consciousness. So what really is consciousness? So this is, all of us know that, isn't it? Consciousness is generally, okay, I think I've not moved the slide. Yeah, so this is the bridging the gap. This is where we are. We are, in medicine, we act like an adjunct rather than replacement. So the next 3 slides will talk about consciousness. So we have to know what is normal before we tap into what is abnormal, right? So it's generally, if you look at literature, it's generally understood as awareness. So awareness of what? Awareness of everything. Awareness of sensations, thoughts, memories, feelings, and the environment, both outside and within ourselves, isn't it? So it encompasses everything you experience, from the taste of food or the pain of a toothache to your inner thoughts and moment-to-moment decision-making. This subjective experience is what makes consciousness both fundamental to human life and exceptionally hard to define or measure objectively. So if we go to abnormalities, to do anything like deep brain stimulation, so what are the different descriptions what are the type of clinical patients that we will address upon? So these are some of the types. So before we go on to before we go on to abnormality, we'll just see what are the different descriptions that we know of. One is awareness, that is the state of being awake and able to perceive internal states like thoughts, emotions, etc., and external stimuli like sound, sight, etc. Then what is subjectivity? Now, subjectivity is each person's consciousness is unique to themselves, isn't it? I won't know what you're feeling, what you're thinking about any particular situation. So each person's consciousness is unique. Only the individual has direct access to what their own experience feels like. So next is about this consciousness. They say it's a phenomenal experience. So what it's like to experience something, for instance, the specific way blue looks or cinnamon smells to you. So that's very individual. Also, the other things that are described about consciousness are, it is introspective and it's a self-reflection. That is the ability to observe and report on one's own mental states, often described by philosophers as introspective consciousness. Now, so these past 3 slides were about normal. All these are normal. Apart from these, there are other states which we will see in anatomy in further slides. Next, we go on to, there's one thing called unity and continuity. This is another part of the description. Although your thoughts and experiences shift from moment to moment, consciousness feels like a continuous stream. That means if we are talking of something in time or temporal. So, if coming to abnormal states, to choose a topic like deep brain stimulation, what are the things, like what are the states that we see any experimenter choosing or application of this? So one is when they are in what is called as coma, unconscious. The patient is completely unconscious, cannot be awakened. So we know that, isn't it? They have their eyes closed with no sleep-wake cycles. There's no awareness of self or environment, and no purposeful response to any stimuli that we give. So we say that the person is unconscious. Then what is this next state? Unresponsive wakefulness syndrome or state. So patient may appear awake, that is, eyes open, sleep-wake cycle present, but show no behavioral evidence of awareness. Reflexes and basic autonomic functions are intact, but there's no purposeful response to your stimuli, to my stimuli, isn't it? So that is the unresponsive wakefulness state, also called as UWS. The next is minimally conscious state. So the person shows minimal but definite behavioral evidence of self or environmental awareness, such as following simple commands or purposeful movement. So the awareness is present but extremely limited, and responsiveness may be inconsistent or fluctuate over time, but they're still responding to you. Then what happens when this same minimally conscious state person recovers? So the recovery may be not consistent, and so there's this post-traumatic confusional state. So this is one other category where people are chosen to, if at all, anything like deep brain stimulation. So this follows emergence from a minimally conscious state and is marked by confusion, inattention, disorientation, memory disturbance, and fluctuating levels of cognitive function and alertness. So it often includes behavioral disturbances such as agitation or emotional instability. So in the past few slides, we have seen what is normal, that is consciousness. Next, we saw what type of patients are chosen to do, if you want to do at all, deep brain stimulation. Now we will see in this, what is deep brain stimulation? So deep brain stimulation is described as a surgical treatment that involves implanting thin electrodes or wires into specific areas of brain. So like how it's shown in the picture. So, okay, sorry. I think I've gone on to, I think it, go back to the previous. Yeah, sorry. So, so this is a surgical treatment that involves implanting thin electrodes into specific areas of the brain. These electrodes are connected by wires that run underneath the skin to a small programmable device called an implantable pulse generator. You can see that pulse generator, which is typically placed under the skin of the chest. The device delivers controlled electrical impulses to the implanted brain region. So can you imagine? There's a wire going deep within the brain to your area of interest. So that is, so that's what is actually what began as deep brain stimulation, but it's gone on to beyond that. So now, so whom do we really choose patients? So usually, you know, these electrical impulses modulate brain activity and are used to treat very severe neurological and psychiatric conditions, particularly when medications are ineffective or cause significant side effects. Now, common DBS targets include areas associated with movement and mood regulation, such as these areas, that is subthalamic nucleus, globus pallidus, and the thalamus. Now, subthalamic nucleus, globus pallidus, we know those are used for movement disorders, even in places like Bangalore, and I'm sure many other places within India also, for Parkinson's related tremors and other types of disorders, movement disorders within Parkinson's, it's almost regularly used. But for thalamus is what we want for disorders of consciousness, because what I have chosen is to talk on disorders of consciousness. So for that, thalamus and related areas which are to do with consciousness. Now, so if we want to do we want to try out neuromodulatory effects using deep brain stimulation for disorders of consciousness. So I think we teach the students that for any stimuli to become, for a person to be conscious, it has to reach the thalamus. So there are two regions in which literature says that, in literature we find two regions which are normally used to treat such patients, and that is centromedian parafascicular nuclear complex, and also the central thalamus, because of their critical roles in arousal and awareness. Now, so we are, all of us as anatomists here, we are aware of the numerous connections and the vantage point of the thalamus. Deep down, there's the reticular formation, and we can recollect that the tegmental area, central tegmental area, so from there, which handles all the reflexes coming up to there, so that is taken to the different regions of the thalamus, isn't it? So we are quite aware of the lateral geniculate body, the medial geniculate body, which are to do with the hearing and the vision. And similarly, in this picture, we can see that it has connections with movement areas, that is the subthalamic nucleus, all these which you can see here. And also, importantly, it has connections with all sensory organs, and then also with the autonomic nervous system, which has to bypass this area. So we will see more of this. And then there's also the hypothalamus, and not only the hypothalamus, there's also the hippocampus and the amygdala. Hippocampus, all of us know here as teachers, is to do with the different types of memory. And what about the amygdala? That is to do with all the fear and anxiety and all that has being regulated. So what happens to all these? They come here, they have an interaction, and then something is filtered, and then it has to go to higher areas. So we realize that it doesn't stop here. It goes to all the different cortices of the brain. For example, the visual, whatever is coming from the visual, those have to bypass the thalamus, and then it has to go to the visual cortex. But before that, we are talking of consciousness, and where is consciousness in all this, in the whole scheme of things in anatomy? So that we are going to see further. Now, if you take, when we stick to disorders of consciousness and what deep brain stimulators have tried to do in different parts of all over the world, whatever is little they have tried to apply, we can see that, there's the pie diagram there. So you can see that, you can see the parameters there, like 50 hertz, and then 100 hertz, 25 hertz. So this is the usual parameters and the voltage, irrespective of what study you apply. Two regions which are seen here are the centromedian parafascicular nucleus and the central nuclei of the thalamus. So by central nuclei of thalamus, we learn that, you will see those, you can see there, when they actually do they zero down the research to the thalamus, I don't teach the students saying first order thalamic nuclei, higher order thalamic nuclei. So first order thalamic nuclei, what are they meaning by that? They're meaning the lateral and the medial geniculate body, and these nuclei which are the periphery. What are they meaning by higher order nuclei? They are meaning the all those the neurons that are running in the white matter, more central in the central thalamus. So they are calling that as the higher order nuclei in the thalamus, and then the blue indicates the cortical regions of interest. So when we see systematically when we do the review of literature, we find that 4 in 10 patients respond, but when they choose the proper patient, otherwise the patient may back off, as we will see in the next slide. They may not continue in the study. So we use the coma recovery scale. So when they do the coma recovery scale, this is what either they may respond in any of these mode of stimuli. So the protocols used are, it's between 25 and 100 hertz frequency, pulse width around 120 milliseconds, and voltages 0 to 4. And the other thing is, like, it has to become a very personalized medicine. We can't imagine leaving the wire, somewhere in the brain, isn't it? So, because the patient may require, as and when the patient responds, the stimuli required has also to change. So now, what we find now is the better study is adaptive deep brain stimulation, because then if the patient responds, then if there's no need of a further stimuli, it's going to stop there. Yeah. Now, any such study, we can expect it to be a very, it's not an easy study, isn't it? It's something out of the box type of study, because when we think of this type of stimulation, and also it's difficult to compare populations because they're from different regions, and we don't know if they find all of who have done this research, we don't know if they are sticking to the protocol. So we're not sure, and so it's difficult to compare. But one thing that is, if the patient is chosen carefully, and that is the third category, that is the minimally conscious state patient, then they have found recovery. So, and that is compared to the people who are resistant to treatment, so they found that these people have responded far more. So we have to know the mechanistic insights of how this works. So DBS of thalamic targets is believed to enhance arousal by modulating the thalamocortical networks essential for consciousness. So the thing is, we may want to stimulate one area, but we realize that there's a functional improvement, yes, but it may be the large-scale brain, it may lead to a large-scale brain stimulation. So, we don't know where we are. The patient may improve, but really we don't know much about the mechanistic insight. And the consciousness improves, and so the patient has improved. So we don't know whether improvement is because of the deep brain stimulation or because the patient has improved in consciousness. Nevertheless, other than deep brain stimulation, it's being used in all these conditions, which are many of them, as you can see, are motor disorders, and of course some others are obsessive compulsive disorders, and also it is thought to be a potential treatment for chronic pain, depression, cluster headaches, addiction, and other investigations. Yeah. So this is what I was talking about. So now in our own study, which was not deep brain stimulation, but 2 of my PhD students did on 2 separate areas. We chose normal rats. And we gave them what is called as equivalent to the ECT in adult, shock treatment. We gave it in the rats. You call it as ECS. And then we got fantastic results. We don't expect such results. So what happened is, in the hippocampus, the cells and the connections changed, and the size increased. So which is, if you correlate it with the clinical improvement, that means memory has improved, connections have developed, better connections have developed. And the other one is, in amygdala what happened? It shrank, especially one particular type of cell really shrank, what we were trying to do. And so that means abnormal connections abated, it decreased. So amygdala we know is to do with fear and fear and anxiety, etc. So that abated. So then I realized that this is also actually translational research, because whatever research we do in animals, or even without animals, like we may use artificial intelligence, and we may do something in using our students, we might we can, I think we can contribute a lot towards such research, especially because of the AI, which is there now. But if we go back to the first slide, which I was talking, we were talking of what is normal and what is, consciousness, because being conscious is really normal. So one of the spiritual leaders has described consciousness, and you'll really say that consciousness is actually the sentiency principle, isn't it? The life-giving principle. So it's not a part, product, or property of the body. We are all trying to see, we are all trying to figure out and put a finger on where consciousness could be in the body. But what does the literature say? It says that it's not it's just a spiritual literature. So, okay, so can I continue? I'll continue the talk. It's okay. All right. So it's not a part, product, or property of the body. It's an independent entity which pervades and enlivens the body. It's not limited by the consciousness is not limited by the boundaries of this body. So just as an analogy, light illuminates the hand, and it's not a part, product, or property of the body. The light is not a part, product, or property of the body. And when the hand is withdrawn, light still exists, isn't it? So I just read out this slide. It's an independent entity. Consciousness is an independent entity which is not limited by boundaries of this body. But the hand cannot be seen without the light. So this is what it does. Yeah. So our own spiritual literature, Bhagavad Gita, BG for short, or any other literature, not necessarily the Bhagavad Gita. In Bhagavad Gita, these are written. So if you just substitute Atma, wherever Atma is there, for consciousness, because consciousness is, that's what we believe. So it is described in all these steps, right? Like consciousness is eternal, that is the truth. And then it is all pervading, Sarvagata, it is all pervading. And one more thing is, it's aprameya, that means it's very subjective, because it's not, it is, the sense organs cannot describe it, because it's something other than anything, it's other than all these, what we experience. Even it's beyond the thought, it's beyond memory, it's beyond feelings, it's beyond what you see, so it's something beyond that. But all these have to, for it to exist, consciousness is required. So that is the meaning. And then also the fifth point says it's very independent of that, because, and so there are those two principles of, for action you require consciousness, but it is not directly acting. And then it's also, it doesn't undergo the modification which everything else undergoes in the body, including the thought, memory, the ego, then the sense organs, everything. But what you will be surprised is that the last thing which is there in red, there are studies on consciousness. There's a paper which says consciousness here, there, and everywhere. So that was by a PhD student, PhD thesis, supported by I think, Jewish government, and in part, probably at least, and the work done in USA, in Atlanta. It was so it's there. So, and even here I've seen many centers, spiritual centers, asking for studies to be done on consciousness. So now, where are we with respect to being anatomists? Where are we with respect to all these? Now, if I go to the next slide here. Yeah. Yeah, can you see there? So even yesterday, I think in one of the talks, or more than one talk, we realized that, we were told that, so that's really where we stand, 0.5 to not even 5% probably, isn't it? And all the other things which the body does, everything is more in the subconscious state, subconscious. So that is what, everything, every single thing is being handled in the subconscious state. So when a part of the body is not able to, whatever is most important is brought to the conscious state to handle that. So the salient feature, so that means there's a place in the brain which picks up salient features and presents to the consciousness to act what is most important at that time, right? So we'll go back to the previous slide. Yes, now here, yesterday I think I read somewhere, one of the publications here was speaking on insula. So insula is supposed to be one region where you want to do some experiment on consciousness. The other thing which I found out was the claustrum. The claustrum is hypothesized to act as a command center controlling consciousness across the brain by connecting neurons in the various regions, prefrontal lobe, posterior frontal sulcus, and occipital lobe. Now there's also, and then if you come down below that, we are aware of this ascending reticular activating system in the brainstem, along with the central thalamus and the other regions, basal forebrain, which support arousal aspect of the consciousness. So these are different levels, isn't it? Awakening is one level when we are really, when it goes, awakening is the last level. Below that there's the arousal, then there's the alertness. So alertness is managed by the lower level, that is the brainstem, especially the tegmentum. So it's also, literature says that damage to the posterior cortex area often leads to persistent unconscious states, suggesting their critical role in consciousness awareness. So that is where we are when we decide the people who are resistant to treatment amongst those 4 categories which I showed you, coma and then unwakefulness syndrome and minimally conscious state and the other one, post-traumatic. So we are at that level when really a patient meets with an accident or they are refractive to the many treatments. So then we may think of this. So this is what, this is the key slide. But the thing is, we have to realize that we are at the tip of the iceberg. In whatever state we are in, we are not, any alternate therapy, any alternate medicine also, or even different types of meditations. So what do? We are addressing the subconscious state. We're made to address the subconscious state and raise our level of consciousness, isn't it? All the different types of meditation, including the chakra or whatever else. So, so if we go to the lower level, that is the subconscious mind, so what are the functional aspects of the subconscious mind? Importantly, it's to do with the autonomic nervous system, and then it's called as the second system. What does it do? Basically, it filters the sensory information, preventing us from becoming overwhelmed by constant sensory input, allowing the conscious mind to focus on higher cognition and decision making. That means, so that's why we say, isn't it? It's stuffed in. Whatever we're not conscious about is stuffed in. It could be in this life, or we don't know. It could be from whatever types of different memories are there. But we can't handle everything. So only it's filtered. So it's really filtered and then given to the conscious mind to make a decision and to act on that particular thing at that time. So, and it's also said that skills and learned behaviors, like sometimes they say that to really learn a behavior very well, some complex behaviors, you have to put in like 10,000 hours, so that may not be necessary for everything, but for it to move from a conscious state, like for example, to put it into for it to become a subconscious processing and the autonomic functions to act normally, like for example, driving a car or riding a bicycle. So that means that we are conscious of that, whatever we are learning, and then we become so learned in that it becomes a part of our memory and our system, and it goes on automatically. Yeah, so this is what we're talking about. I think this is over. Okay. Now, in the subconscious also, we have all those memories, the deep-seated beliefs, memories. So if you look at hippocampus, there's a CA1 area, CA2 area, CA3 area, and the different types of memories, long-term, short-term, and etc., and something that connects the two. And then the different dispositions, the different behavior, how my behavior or my particular disposition to anything is my response. So some say that those even acquired from past life experiences according to some philosophical perspectives, which may not be wrong because we are talking of heredity and that may be stored in genes, etc. So we know that in this way we know that it works as a repository for creativity, imagination, perception, emotional responses, so all of which strongly influence behavior, often without the conscious mind being aware of the underlying process. So all the time it is the subconscious mind and unconscious mind which is handling as much as is possible. And then when it can be addressed, it comes to this. And how does it, so there are various processes, and some of it is the creativity, where we work out and we manage our own, we have skills and then we manage our life. And then there's, so if there's something which is beyond that, so if we think of, so all these regions, that is basal ganglia, which is involved in habits and automatic behavior, then the amygdala, which processes emotions and the emotional memories that influence the subconscious reactions, because the amygdala and hippocampus and most of their limbic system are very closely related. They have connections. And what is this default mode network? So it is like most of the time we are not concentrating on any one thing and wanting to do that one thing alone, isn't it? So that's it's active during rest and involved in introspection and memory integration. So that keeps happening by itself, because whatever was presented to me when I was 30 years ago or when I was many years ago, so the same thing doesn't hold good now, because my memory is constantly integrating and changing depending upon it is very contextual, right? And then coming to hippocampus, it consolidates the memories that shape subconscious beliefs. So that's continuously happening. So for example, if consciously I'm aware of something, and then unknowingly or knowingly that goes to my subconscious mind, and then there's a change, there's a shift in my learning process of what I thought of something that happened long ago and what I'm thinking of that now and what I make of it. And then for goal setting, we have this prefrontal cortex, and also for decision making, but are more conscious in nature. That is, when it comes to the prefrontal cortex or any beyond this, after workings underneath the subconscious mind, then we become aware of it, and after the decision is taken, we start to work on it. So now, when we have been interested in consciousness, so the two regions, at least minimum two regions, apart from all these, which which we can see in literature, are insula and the related brain regions, and the other is the claustrum. So the insular cortex is as we know, is a deeply situated brain region involved in diverse functions, including gustatory, sensory motor processing, risk-reward behavior, autonomic functions, pain pathways, and all other like auditory, vestibular functions. And it's subdivided into three regions again, which we don't teach we definitely don't teach the undergraduates, but probably postgraduates, yes. So there's a dorsal anterior, ventral anterior, and then there's there's an anterior, there's a ventral, and a dorsal, there's a middle region, and each with different functions. So anterior insula connects to emotional processing regions like the amygdala and anterior cingulate cortex. Posterior insula connects more with cognitive processing areas. So basically, what does the insula do? It integrates bodily sensations with emotions and cognitive information, acting as a hub for saliency detection. So what is saliency detection? The salient, whatever is most important, is detected. All others are again stuffed in the same areas, stuffed deeper for now or for later. And then also it takes charge of cognitive control and error processing. So error processing is what the body expects to happen and what something else happens. So that error processing. So this is one area. Okay, now the insula's extensive connections includes links with frontal, temporal, parietal lobes, limbic structure, including the amygdala, hippocampus, basal ganglia, and it's not limited to only these. Now, what is its connection with whatever we've been reading till now about the different areas, possibly in the insula or the claustrum or all these, to do with the disease which shows up, and many of which may be resistant to treatment. So this yellow here, what you can see, so that is the insula, and we can see that that's divided into something in front, connections with front and anteriorly, posteriorly, and then it's also connected with all that we talked of, limbic system, including amygdala and the hippocampus. Now there's something here which you can see in front in green. You can see that if there's a mismatch signal, so then the particular cortex, prefrontal cortex, is supposed to, and even in that there's a particular region. So I'm not going into very great details because of the paucity of time, and not only, this is not, I mean, I've not done research in that to talk here. So if there's a, I'm just picking out what is contextual here. So if there's a mismatch in signal, then it has to select the proper response for decision making and for motor preparation for that particular organ to act. Now what happens if there's a mismatch? You can see this in green. I'm scared to touch this because if this doesn't work, then oh well, it's working. So you can see here, what is interoceptive prediction error? That is the difference between what the brain expects the body signals to be and what the actual body signal afferents are increasingly recognized as an essential factor contributing to these disorders: anxiety, mood, eating, substance use, somatic symptom disorders. So, if the subconscious mind is not able to handle, then it can result in all these, and this is where something like some form of treatment other than the regular form of treatment comes into picture. So adaptive deep brain stimulation is one which I have not touched, but really, we are quite in tune, I think, especially with the AI. I think we are in a vantage place, at least with our medical students and PhD students and whoever else, and our MD students, to give them some topic and to really go forward. So even in people who have done this DBS, deep brain stimulation, when they are in disorders of consciousness, when they've chosen the proper category, that is minimally conscious state, then they have observed over a period of 1 to 7 years, they have observed that neuroplastic changes and network reorganization associated with clinical recovery have been observed. So what do we mean by neuroplastic changes? That is, there's a reorganization both in fibers and cells. But the important thing is, we don't know whether that deep brain stimulation is the cause of the recovery or regained consciousness has contributed to recovery. We still don't know. And we have to admit that most research, after 10 years or after some years, that becomes obsolete, isn't it? So we say research, but really we are not in a good place. But what is our role? We can, I think, our role as academicians, as researchers, especially with the use of AI, we can, with the help of AI, with regions of our personal interest, because if we don't have a personal interest in any area, isn't it? So if somebody whom you know has been affected, you want to do something, so that it's better to choose that area because our interest will be sustained, and we can always use our medical students, etc., isn't it? even an AI can benefit, can help us. So though AI has taken a big step, extremely big step, I believe, I mean, I was just told recently, it's begun to ask itself, because from AI you get all your answers, isn't it? So AI has begun to ask itself, where is my consciousness? So, so that is, it's finding itself a threat. So it must be true, because someone told me just 3 days ago. Well, okay, so we are in a good place, I think, as academicians, and really, I think a lot of it goes, isn't it? We can't do everything, but as researchers and academicians, and we can stimulate interest, which was the basic point of this talk. So this picture is from RHS Garden, and that is in Manchester, so which I just visited 1 month ago. So wherever you travel, I travel the world all to find myself. So you see that self, S is in a capital letter. So wherever you go, you are back to your own, you want to, you'll find your real consciousness within yourself. So, so these are few of my references. And then, so that's the end of my presentation, and thank you for this, for the, this very, for me, it made a lot of good things for me, because I really, I had the opportunity to, as the previous speaker said, it gave me the opportunity to really get into and know more about myself also, as much as AI helped me in this particular topic. Thank you. Yes.
Thank you, madam. What madam talked about is, just to summarize, there will be deep brain stimulation treatments. Nowadays, it is happening in our field also, everywhere. Along with the psychiatrist, I feel, along with the psychiatrist, neurosurgeon should involve in this, probably. That will be a very good idea. And the most important thing is coma or unconscious maybe of anything, injury, maybe infections, maybe diseases, or genetically also. Most probably, I think this will be induced to treat the Parkinson's disease and other things.
Yes.
So that is the main thing. So we are thankful to Madam, Rupa Madam, for giving us an interesting guest lecture. So, any questions are there from the audience?
Yes, please. So, Madam, about the consciousness we are mentioning, probably you know that you might have, I think, come across with Mother and Sri Aurobindo's Pondicherry. I don't know whether you have come across
Auroville.
Auroville and this whole Mother and Sri Aurobindo. So, like what they say is, there is a consciousness called as nascent consciousness. And that nascent consciousness is responsible for maintaining the atomic structure of all this. Like for example, magnesium. Magnesium has 12 protons, 12 neutrons, 12 electrons. To maintain that and to call it as magnesium, there is a consciousness.
Yes,
and
sir.
that they call it as nascent consciousness.
Okay, yes.
So
Yes.
then comes like there are different gradations. Like after that, inconscient consciousness, then comes like for example, whatever we see here, mat, etc. These are all inconscient consciousness. Then inconscient, then conscient. Conscient is this what right now you're telling, we are listening, trying to grasp. This is all conscient consciousness. Even after that, there are different levels. And especially when you come, I will just skip other levels. If you come to the mental consciousness also, then there are what is called as the intelligent consciousness, spiritual consciousness, then higher consciousness, that of course they call it as higher mind, then overmind and supermind and beyond supermind. So probably you might have come across with these things. I think all these are going to be in our brain already, but they are still what you call it as in they have not been totally come into action, because release of each level is going to come out, it is going to bring about tremendous amount of energy. Like for example, we say the hydrogen bomb. So to maintain that atomic number and split it, the amount of, you can see the atomic bomb, which is literally destroyed this Hiroshima and Nagasaki. Just to
Yes,
separate
sir,
this.
that's very true what you're
So
saying.
like that energy, just release it. Probably here also we have.
Yes, sir.
that
Only for
combat-
the task that we are meant to do at that time.
At that
Yes,
time, and then
that's
not
all.
only that.
We can't handle the whole thing. So
Can't
only a
it's
little,
just
little is-
impossible. So,
Yes.
I mean, like body is just evolving
Yes.
to contain that energy, and now it is releasing in stepwise fashion.
Yes, sir.
So I think here these things are arranged in such a way.
Yeah, so
that-
that's, so some say it's for whatever we do, whatever act we do, what we decide we can do. So, it's like, if you look at, the sense organs, so what is, just the eye can't do anything. It's the sight, right? So just sight can't do anything. It has to integrate with other regions. So even just the mind can't do anything. So there's the thought. Even thought, brain can't do anything. Intelligence, isn't it?
Correct.
So whole life is about purification, right? So that we grasp, and there's no logic between, yesterday Kanta ma'am was telling about the guest speaker. So he's a realized soul. So what's the meaning of that? To me, it occurs that he is receptive to the universal, the consciousness, yes.
So I would like, as you are telling, is consciousness cannot be defined because it requires, if at all we tend to define, means again we are making the finite things.
Yes, sir.
It's infinite.
It's infinite,
It's
yes.
infinite.
Very
but,
true.
I mean, like, that's why.
You can't even call it as, just, you can't name it.
And language has to develop, I think, to express that, the experience of
No,
that.
the thing is, it is said, at least in the spiritual books, that you can't, it's not graspable by anything.
I think it is graspable, but it is difficult to express it. It is
Yeah, so when it's graspable to whoever it's graspable, they're not able to express
it. It is indescribable. I think you know Kannada, madam?
Yeah, how to go to
So it is
Kannada.
like Shabdatita, Varnanatita. You
ಹೌದು
can't
sir.
just, but one can experience it.
Yes, sir.
Just
I
wanted to
experience
say.
Madoro, each one's experience is different, isn't it?
That is
Because we can't
because there is the individualization has
Yes.
developed
ಹೌದು
over a
sir.
period
Ego,
of
ego
time.
also has to
So
be
you can call it as ego consciousness, and
Yes.
ego is necessary.
Necessary,
And gradually it has to be released.
Yes.
So I think I just tried to correlate with that in your
Yeah,
slides,
that
madam.
one slide had, yes, sir. The
So-
one in Bhagavad Gita, yes. I think.
Thank you, madam.
Thank you, sir. Thank you.
It was a wonderful narrations by Dr. Rupa madam. Yeah, the conscious level, okay, we really understood about. Dr. Kulkarni also has a bit of a clear point. And madam, you have also put one particular slide, Bhagavad Gita.
Yes.
That is absolutely a fantastic way of. But now the deep brain stimulus thing, what we have, the recent advance in medicine.
Yes.
So that might definitely help people who are really unconscious, that we say vegetative state of mind, patient that what you say in the hospitals, and the minimum level of unconscious people. So this DBS can definitely help, and I hope that in recent advances medicine may prevail in future also, and may give a new sense of hope.
Yes, sir.
In this
Because
field.
we also have these different types of karmas, right? Prarabdha karma and Sanchita karma and all. So that alone, there'll be a purpose for that life, right? So if in that way, probably that minimally conscious state person is going to
but
recover to a
now-
certain extent, and then
But this is how just a lighter part of way, like we see on films also, we see that one film like Sanjay Datta, that one fellow was there on the wheelchair, and then how that person came into the conscious.
very true, sir.
So that how that emotion, the way you treat, the way you present in front of that, that also might help somewhere.
Yes,
So
sir.
that is also.
Yeah,
can
we have
help.
to be very, detached, passionate about our work, but detached from that situation to do really our best.
Yes.
When we get absorbed in something, then it's not going to, we should not have our, we have to do our best and leave it, right? So everything is in a capsule, that's already.
Thank you so
You're
much,
right.
madam. Thank you so
Thank you,
much
thank
for a
you,
beautiful
thank you very
presentation.
much
Thank you so much.
to the organizers for giving me this opportunity to talk this topic here. Thank you. I hope I stuck to the time. I don't know. Oh, sure. Yes, 2 minutes. Yeah, sure.
We extend our heartfelt thanks to Dr. Rupa Ravindranath Madam for that thought-provoking session, shedding light on the role of deep brain stimulation in regaining consciousness. May I request distinguished chairpersons to kindly give away a token of gratitude to Dr. Rupa Ravindranath Madam, and also I request Mrs. Asha Deshpande Madam to kindly join. We also place on record our sincere gratitude to our esteemed chairpersons, Dr. G.M. Mahesh sir and Dr. Udayan Kudalka sir, for their scholarly presence, gracious moderation, and for guiding the session with both academic depth and refined decorum. May I request Professor Dr. Veena Kulkarni Madam to kindly give away the token of gratitude to the respected chairpersons. We now enter a session that reflects on the very core of what we do as anatomists, teaching. In this ever-evolving landscape of medical education, innovation and methodology is not just an option, but a necessity. We are privileged to welcome Dr. Lata V. Prabhu Madam, Professor and ex-Head of the Department of Anatomy, Center for Basic Sciences, Kasturba Medical College, Mangalore. Madam will be speaking on the topic, Evolution of Teaching Methodology in Human Anatomy. To chair this session, we are joined by two highly respected chairpersons, Dr. Meenakshi Parthasarathi Madam, Professor, Sri Atal Bihari Vajpayee Medical College and Research Institute, Bengaluru, and Dr. S.K. Deshpande Sir, Professor, SDM College of Medical Sciences and Hospital. May I welcome my beloved teacher, Dr. Lata V. Prabhu, on stage. Thank you, ma'am.
May I request the chairpersons to kindly come forward and introduce the speaker.
Good morning, one and all. Welcome, Madam Lata V. Prabhu. She is Professor and ex-Head of the Department of Anatomy, Center for Basic Science, Kasturba Medical College, Mangalore. Dr. Lata V. Prabhu is a seasoned academician and researcher with over 3 decades of dedicated services in the field of anatomy and research. Madam's academic journey includes MBBS from Mysore Medical College, MS from Anatomy, MS Anatomy from Kasturba Medical College, Mangalore University, and she is the best outgoing lady candidate of Mysore Medical College and also receives the 4 gold medal awards for surgery and gynecology. Madam has more than 36 years of teaching and research experience, and Madam has made significant contributions to academic research, having published over 195 papers in reputed national and international journals and actively guided several MD postgraduates and PhD scholars. Madam was appointed as Chairman of Board of Studies of Anatomy, MAHE 206 to 2012, and was the head of the department of KMC MAHE. She is also a life member of prestigious body like Anatomical Society of India, Indian Medical Society, and SOCA. Madam has conducted and attended more than 93 conferences, CMEs, and workshops. She has authored the textbook of histology for the undergraduates and received the awards of excellence in medical literature every year since 2007 during the award day celebrations held by KMC Mangalore. Received Good Teacher Award 5 times from KMC Mangalore. In addition to her academic pursuits, she plays a key role in curriculum development, accreditation process, and community outreach, and has received multiple awards for her excellence in teaching and research. Welcome, ma'am. Waiting for your presentation. Thank you.
A very good morning to everyone. I'm not the kind of person who can stand on the podium and talk. I'm not used to it, so I've asked for a hand mic. And I want a lot of audience response in this talk, so I request all of you to come forwards. I will not ask you any questions. This is what I do in the classroom, because most of the students, they feel that if they're sitting on the front bench, I will ask questions. So please, especially postgraduate students, the future anatomists, please come forward, because now we have evolved up to artificial intelligence. So I would like to share my thoughts, because my career started in the year 1988 when I joined as a postgraduate in anatomy, a fresh graduate, and I have evolved a lot. My methodology of teaching has evolved a lot. So I feel a closer audience, and because it is the end of the session, hardly anybody is there. Doesn't matter, because this is what happens in our classroom also. So many times students are not with us. So let me start with the topic. So this is the latest one on the evolution. So you can see here how we have reached at this stage. Actually, now we have gone beyond this. We are all under the influence of AI tools. Now I started like this, because that was the year 1988. Now let us see the word evolution, okay? What do you, let us see the word evolution first. Gradual ongoing development, that is called as evolution, because whenever I describe some structure in anatomy, I tell them to split it up and then understand. So let's not take it for granted that everybody knows what evolution is. Generally we know, gradual development. And second thing is philosophy. It should follow the philosophy and practice of education system. If it is evolution of education system, it should follow the philosophy. And it should enhance the learning process. So these are the aspects, and we have to apply it only for anatomy in this particular juncture. I'm not going into the clinical aspect of worldwide thought about evolution in education, only about anatomy, because I'm an anatomy professor. Now coming to the, and at par with the technology. So what has happened is, when we started this journey of teaching, it started with lectures. And now, slowly we have evolved with the advent of technology, which I am going to show you slowly how we have evolved. I am not going to talk about the history of anatomy. That what has happened in 19th century, up to the 20th century, it was the same. Teacher-centric teaching, sage from the stage. You sit there, you talk, people listen to you and say, yes, yes, sir. That was the way of it was teaching going on. I can say up to the end of 20th century. So I'm not going to talk how, the first anatomist, he got the cadaver from the grave and started dissecting. Yes, our Gray's Anatomy is the Mahabharata, Ramayana, Bible, Quran of all the religions. For anatomists, it is ultimate. And it's a wonderful textbook because nobody can repeat it. With that minimum lack of technology, such a huge book has been written about human anatomy. So my utmost pranam to Gray's Anatomy. First I would give then let me see what is the objective of this evolution. Can anybody tell me what is the objective? Why we have to evolve? Is it to teach in a better way or make the students learn? What I feel is the main objective is to learn. Make the student learn and improve their cognitive skills. Because now is the advent of maximum technology. We have invented AI tools. So we have to go, then to go at par with these students, we have to evolve. As teachers, we can't go on sticking to our traditional way of teaching, but I will tell you pros and cons of that. Now we'll go to the next one. First one is the subject. As all of you know, subject of anatomy is not a straight line. It is complex. It is difficult. And that also first time students coming from pre-university, he is flabbergasted to see the cadaver in the dissection hall and the Greek and Latin terminology and also different sections of anatomy. And that too, when I was a student in 1981, I was in Dr. Kanta Madam's batch in Mysore Medical College. We were only 75 students in one class. Now you see the amount of students in the class. 250 students are there. And that too, in 9 months, we have to finish first MBBS. In fact, it is sometimes less than 9 months, premature delivery. 1.5 years of learning anatomy and learning, that also CBME. We have to teach them within 9 months, and then we have to deliver good students to the second MBBS class. So it is a big task for us. Anatomy is complex because we have got various sections. As all of you know, I don't have to tell you. See, what are the parts? Skeletal anatomy, surface anatomy, radiological anatomy, clinical anatomy, genetics, and developmental anatomy. All these has been taught in less than 9 months. And then they tell us, use technology. And latest one is CBME. That is, what is CBME? Competency based. It becomes still difficult. Okay, now we'll go to the next slide. I would like to describe our evolution at 3 levels, which was mainly used by Maurice L. Big in 1967. He had actually described these levels of teaching, how it evolves. So at the bottom of the pyramid, we see memory level. Now this is what I did and what I learned from teachers. Let us see the parts of it up to the 20th century and before. Because I graduated in the year 1986 from Mysore Medical College, and immediately I joined KMC as tutor. And up to the turn of the century, I can say turn, millennium, up to 2000, it was level 1 only. Nothing changed during that time. And that is why I say 20th century and before, the teaching technology, the assessment technology was the same. Let us see the parts of it. It was teacher-centric. All responsibility was on us. We have to teach, but the one beautiful part of it, we were not assessed that time. There was nothing called student feedback. You come there and you talk. You go on talking. And if somebody asks question, ಏನು ಅಧಿಕ ಪ್ರಸಂಗ ಮಾಡ್ತಿ ಸುಮ್ಮನೆ ಕೂತ್ಕೋ notes ತಕೋ. And those students were, and we were also very scared. You know, my teacher was Dr. Thakar Naik, Dr. Vishwanath, and a stalwart Madam Kanta. She used to teach embryology. And she used to draw diagrams on the board. And we should replica the same way, same color pencils, same way. And when she asks the question, we have to repeat the same sentences she says. So that's called rote learning. But I will never look down upon it because it improves your one skill, memory. Even now my memory is good thanks to Kanta madam, because she used to insist, you have to repeat. This is the way it should be. Traditional teaching, that is called as traditional way of teaching. Student is held responsible. You teach. The responsibility is now on the student. The student has to sit in the class, listen to that, go and open a textbook, write the notes. All these things were not there. Only one small record player we had that time. We'll put in the ear and sometime we'll try to practice it. None of our senses was stimulated except vision, writing, and whatever we hear. There was nothing was there, not even a mobile. Even we have to call the parents, we have to go to STD booth and talk. Under these circumstances, we studied. But we were good because it was all on us. Teacher will come and, what were you doing in the class? You stupid fellow. What was I doing? I was listening, but I cannot recollect now because I am scared of you. Okay? That fear was a fear and respect, that mixture was there, but that made us learn actually. But nowadays the scenario is different, I'll talk about it. Traditional evaluation, Viva OSA, written examination, all this will go on and everything. And over that, we have dissection exam. We have to prepare the slide. Everything is on us, we have to do it. And sometimes even the greatest merit student will fail in first MBBS because you are given dissection of pterygopalatine fossa. It depends on what you get for dissection. So this traditional way of teaching was a level 1. But what I can tell you is, it really refined our cognitive skill. What is that? Memory. Okay. Now we'll go to the second level. This started happening only after 2000. That is the time the Indian Medical Council said, you shall have a medical education cell. You should take student feedback. Till then we were kings. We will stand there and we'll talk, you have to listen, you have to get up and go. You should not ask any questions. Some teachers were little considerate, yes, any questions. And if the fellow said, yes, what you didn't understand in the class, tell me. After that he will forget what he has to ask. Okay, so this level came, the responsibility slowly shifted more and more on the teacher. Again, it is teacher-centric only with lot of responsibilities. So that level is called as understanding thought. So it is our responsibility to make the student understand, not just telling something and getting away from the class. And also they will give you student feedback. Some people will give 0 out of 10. Some people will write some remarks because it is anonymous. But some were afraid she may find our handwriting. Anyways, the student feedback was, so our attitude also changed. The teacher attitude has changed only because of student feedback. It is like having a police, isn't it? We are all very moralistic people. We follow the rules of the society. Why? There is something called a law and order. The law and order is not there, and when you are that is first level, yes, actually we used to call it, give dictation, because you are a dictator that time. So we have gone to now the second level. I can say that after 2000, till now, we are actually at this memory level, that is second level, understanding level, and we are trying to tilt slowly towards the third level. I'll tell you that. So this is called as Gen X, Gen Y, and Gen Z. So up to, I can say, 2000 to 2020, this has gone on. So 2020, actually the evolution happened. You know why? I'll tell you why also. And all of you know why. Up till 2020, it was understanding level. Now we have become little tech savvy. All computers have come. And some of the institutions like KMC gave us MacBook computer. And we were supposed to start PowerPoint presentation. Till then we were going through some chalkboard and trying to use different colors of chalks. Try to make the subject more understanding. But initially we were not bothered. But once I told you, the student feedback came, we realized that we have to impress them. Teacher was now a guide. But I don't believe that. Yeah. Okay. So teacher as a guide, because here you have now come down a little bit. You are no more a sage and everybody says, okay, now you have to listen to me, but they will question us. Excuse me, madam, I have a doubt. And that time, yes, What is your doubt? No, no. Sit down. Bhai much kutko. That was not possible that time. Because teacher is very rude. That a response will come, management will ask you. Because so many private colleges also came up. Government college, it was okay. But once the private college came up, it became totally student-centric. And they used to tell us, this is like your company. They are your customers. Customers' comfort is very important. So we all say change. Second, teacher is responsible. Still, we are only responsible. Technology and interactive. So we started using technology. So we started becoming, do you know how to operate the computer? I still remember we went through the stage and some of them suddenly had a laptop in their hand and they used to walk with the head straight up. One desktop per department. So that was the stage. And now they said that, no, new concept, auspice. Objective structured questions should be asked and evaluation also. Now the third level, which is going to happen, which has not yet happened to our level now, it is happening now because 2019 they introduced CBME. And that time they said, you shall follow the CBME method, where you have to improve the cognitive skills, understanding, collaboration, research of the student. Student is very important, not you. That's what they said. That is why I told all the students, come forwards. You are very important. I am not important here. Okay. So this is called Gen Z. So it happened, now people who are born after 2010, they are alpha group. That is called as Zen Alpha. Their AI tools are with them. And they are coming. When? After 2 years. So you all have to be prepared for them. Zen Alpha is coming. But this, up to 2020, I taught. Zen X I have taught, Zen Y, Zen Z. I have taught every one of them. CBME. So it became competency based. What is competency means? What you teach should be applicable so that the student can practice medicine. Student can collaborate. Student can go into research. Student can become clinically efficient. That was the idea of this CBME. That happened in 2019. Student-centric. So customer friendly. Teacher is facilitator. Guide from the side. I was pretty happy about it. All these days, the entire responsibility was on our shoulder. Now you take the responsibility. I will stand at the side and laugh at you. Now we have become facilitators. But we have to be the expertise. We have to give some clues, cues, small group teaching. Now actually today this is no more a lecture. This has become small group teaching. But students are sitting at different distances. You please come forward. Okay, I can see each one of you. Then, of course, the learning activity started. Case-based learning. You might have heard all these talks now. Problem-based learning. Flipped class is ultimate. Research. Think, analyze, be creative. Evaluation in a higher order. And now, the evaluation has become no more summative. It is happening throughout the year. Throughout the year, we have to observe. We have got log books. We have to observe how they are answering. And according to their way they are answering, we have to mark them. So the assessment also has changed. Internal assessment marks are not counted. It is only eligibility to sit for the exam. So throughout the year, we are on the one leg, watching the student and then showing the management. We have done everything. You have assessed, and now we have a special tool in Kasturba Medical College, students' life cycle. We have to enter everything. Today, the student sneezed in the class. We conducted the exam. He achieved these many marks. His attendance was this much. But I am not responsible. He has a girlfriend. So we have to explain everything in his life cycle. So all these tools are actually making us little jittery. But what has happened to me, you just imagine. I am an old dog learning a new trick. I started in 1988 and or you can say old wine in a new bottle. Okay, whatever it is, I have to perform, otherwise I will perish. Because now I have retired actually in 2024. They have given me little bit of, they ಗಂಟ್ಲ ಮೇಲೆ ನೀರು ಬಿಡೋದು ಅಂತ ಹೇಳ್ತಾರಲ್ಲ. So till they have given me post-retirement engagement. And over that, I come under all this scrutiny by the management. And I have to fulfill everything. But I feel that it will delay my Alzheimer's. It will keep me active. I have taken it in a very positive note, trying to learn. Like I said, old dog trying to learn the new tricks. So this was what it was. Initially, when they did the dissection, one person will open up and others will observe. This is our Manipal dissection hall. All staff are sitting there in one table. Students are distributed. This is actually make-believe. How many people are there in one table now? Bodies are less. The NMC regulation is there should be only not more than 15 or 10 students, they say. In our time, it was 10. Now, 10 multiplied by 2. But sometimes we separate them, we show more tables. How many staff are there, you ask me? You are telling, we are having 10 students per table. Who is teaching skeleton in one of the table? Staff are so less. Nobody is joining MD anatomy. Because joining MD anatomy was a way out during our times. Now we are literally getting into a problem. Research is on you. Student performance is on you. Actually, we should be paid 5 times the clinicians because so much of effort we take. I really feel. North India, they are paying actually. The wave should come to South India because you now see how many people are choosing anatomy as MD. We do not have MDs. And slowly they are telling others can join. I don't know what all amendments they are going to make to increase the staff number. So this was the dissection hall. I don't have to describe it. This was prosection and sometimes cadavers. A madam has got 500 cadavers, it seems. She is very rich lady. And all are very altruistic people in this place, Dharwad. They are all donating. So I wish that the wave will come to Mangalore. We don't have so many bodies, so we do prosection. So we are doing that. So slowly we switched over, cadavers are less. And now we have this virtual reality, Anatomics, 1.5 crores. It has entered into KMC Mangalore. It is a very sophisticated cadaver. It is from America. 2-3 people are there in this. They have got names, Lucy, John, okay? And our poor cadavers sleeping in the dissection hall have no names. Ranganna, Mahadevakka. Nobody is bothered. We say cadaver number 1, 2. Here, we are now today seeing Lucy. Okay? And she is in an AC room. And it is more sacred than the temple. Remove your chappals and enter. So all these things are going on, and we are proud owners of Anatomics for virtual reality. And sometimes, in Mysore Medical College, we had 3 ambulances when in 1988. They used to be in front of the college. What you used to call them? White elephants. So I only hope this doesn't become a white elephant because 250 students at a time, 1 anatomy. How much you can teach using anatomy? It is only used by PGs for some research. They are finding whether students are finding the teacher good or the Lucy lying down in this table is good. And nice name, Anatomeju. Mejina mele malagida anatomy. Okay, so that is the one. Okay. I thought very less people are there. Let us make the session little humorous. Okay, humor is very important in anatomy. Now this is called augmented reality. In augmented reality, all your senses are stimulated. Cadaver they don't want to touch, but they will wear one goggle. 4D, you can see it. Okay, these things also can be done. If your college is very rich enough, you can now go into the next step, that is the 4D, augmented reality. And this is called as interactive museums. One is there in Nimans, I'm sure, where there is a brain museum. So you all have museums. Why museums are called as museums? It is kept in one place and nobody comes there. You can do one research paper. What is the importance of museum with the advent of technology? You can improve it, you can make it interactive. Using AI, you can have buttons there which will light up, which will show. I think some of the colleges might have. That is called interactive museum. where the structures you can see rotating and all that, or it can be just a, computer augmented thing. See, now we are taking this piece by piece. I don't know what is the importance of that. Kachumbar they are making, removing everything and showing. But it's very difficult to learn anatomy. It is just a visual pleasure sometimes, seeing the, subject moving. Now this is our typical histology lab, which we used to do. Give the slide and tell the students to study it under low power and high power. Now high power is taken. You have to just recognize that it is an elephant. That's all. High power means you put the elephant under high power and sometimes you touch the tail. Oh, this is the snake. No. You have to observe the structure at high power, but we don't have time. So all the high power objectives have taken off. How many colleges? High power is almost not there, or it is just, for decorative purposes. So this was going on up till the year 2000. And some people were very proud owners of this slide projector. Ivattu cinema untante. So we were very happy. They used to put the slide and, like that time when TV has come, first time we put black and white TV, somebody was playing Veena. And entire family sat and we watched it. Now how many people watch somebody playing some musical instrument, unless you are a follower of that? We have got variety. All of us have got ADHD nowadays. What is that? Attention deficit hyperactivity disorder. All of us are having. Our attention span is very less. We want a quick, short span of entertainment. What is that? Reels. Yeah, it gives you a big dose of the dopamine. So all that, and all the students, mind you, now you might have watched, I am not insulting anyone, some of the sessions, that person is talking, rest are all in their own world. Okay? I am not insulting the speaker, but that is the truth of today. They have got very short attention span. Okay? Unless they are stimulating that part of their brain. What is that? Brain loves stupidity. You tell jokes or tell some weird word, suddenly they will get up. What did she say? Everybody is laughing. What happened? We want to know. But if it is boring, or you have your mobile, you show attention. Okay, like that. Anyway, we have to accept it. Now we'll go. Now this is the latest one where the microscope is attached to a LCD screen. I am very sure all the colleges have it now. So because we have got a bunch of students coming for every practicals, and we can't go like, we had Saraswati madam, histology. She will go from student to student. Yes, Latapai, I was Latapai that time. Latapai, what did you see? Now we don't have time. If I do 80 times, then I have to put a lumbar belt. Youngsters. So we have this. So we have made our life easy. We have got a LCD screen. Are chalkboards still used in schools? I'm asking. Yes. You go to any lecturer, we are talking big things, small group teaching, CBL, PBL. You go to any lecture hall, even now, the most sophisticated colleges, you have blackboards. You have the same seating arrangement. We say, you should interact. But the seating arrangement is, see, yesterday's night's party. That is the way it should be seated, actually. You should have small tables, having 10 students, whatever they are doing, and you entertain them, and they discuss it. That is the real way of teaching. But this is going on, but still we should, no, we should do discussion, we should do small group teaching. But here I am happy. Then it has become a small group teaching. Black lives matter. So I say blackboard still matters. Just like the black lives, black is here to stay. But I will tell the development, smart board. How many of your colleges have smart boards now? Yes, some smart HODs are lifting their hands. Okay, very few. So the board has changed the colors. Board has become white. Board has become smart. In which way the board has become smart? Even we have in KMC, but within no time it broke down, and after that our poor chalkboard only is playing the role. So I was using that whiteboard, and it has got, you can hyperlink it. You can use internet and show some animation and all that. So smart boards are really nice, provided, I don't know, and many people are afraid to touch it. Actually, it's very simple. They have a small pen, and then you can choose the color, but you should be good in drawing, because I'll tell you why the drawing skill of a teacher has changed. We'll go to the next level. So what is the importance of this? So there is when you have a whiteboard, there will be interaction. Okay? You draw it. But the thing is, what will interact? You are drawing and they're throwing rockets at you. Attention grabbing, brighter screen, low maintenance cost, technology integration. Only this I feel is important. It is integrated with technology. Otherwise, it is just like any other blackboard. The skill is yours. Lecture. So the lecture is the mode of teaching. It's still going on, but only thing is we have to improve it. Because the moment you hear the word, lecture kodbedi. Maneli, if you tell your children, Nodi, hige madbe, Amma lecture beda. Yarige lecture beku? Yarigu beda, if you really ask. Nobody wants lecture. Lecture has got a very negative note. Lecture means lecture, 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 bore, 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 bore. So you have to make the lecture more interesting. The interaction should be good. Lively. So this is my definition. You can change it. You can make it lifeless. Lively means, I do not like the word lecturer. Lecturer means a very boring person. So let them be professors. Any professor, assistant professor, associate professor, additional, extra additional professor, professor. What is the meaning of professor? Profess, confident, in control, great content is a professor. Not like, now if I come to this lecture, already defeated. Today I'm going to talk about evolution, all of you know. That is called confession. So you have to profess. That is very important. Make the sessions. I don't have to tell you, many of you are very well versed. And if you have been doing some mistake, you can change also now. Because that is why you have to go and listen to others. You should, I am a professor. I have got 35 years of experience. I will not. No, you have to learn. If you learn, teacher is the word which has become extinct. You should be a learner. You can learn from your students also. You can learn from your postgraduates also. You can learn from your peers also. Never have that chip on shoulder behavior that I am a professor. I need not learn. Educative, of course. Content should be very good. You should be very well versed with anatomy. It should be creative. Creative means the student should, like we describe the Trendelenburg sign. So what do? When the hip is lifted on the right side, when the foot is on the right side, hip on the other side will sag. Okay, if I don't do that, when you put the pressure, when you stand, if the gluteus medius is damaged on the right side, the left side hip sags. Instead of that, you stand on the right foot. Now you show, always, if your gluteus medius is normal, your hip is lifted always. But if it sags, okay, that we call as, do that and show. Who is the famous Mahabharata character? Shakuni. Okay, Shakuni, that is a sign of evil those days. Or one eye should be closed. All those things are, they say body shaming. You can't do that. But you can always show. And then if both sides are damaged, waddling gait, Trendelenburg test or sign which you do. Then you have to describe what is test and what is sign. So make it creative. Do some sort of a movement. Lordosis, kyphosis, scoliosis. So you can do some movements. So at least we will, your senior citizens will have some exercise also. Okay? Thought-provoking. So that is left to you. The way you talk, it should provoke that thought in them. Oh, this is what it is. Let me find out more about it. Understandable. Some people talk like that. There are some adjunct faculty in our institution. He came to visit us. And he said, I didn't know what to do. I said, yes, sir, yes, sir. And my other, professor was standing there. She is intently saying, yes, yes. Then I said, is it something wrong with my ear? Then I asked her, what did he say? Even I don't know, she said. And this guy takes online classes. Imagine my classroom. where it is so difficult to catch their attention. And this one, so make it understandable, please. Okay? Relevant. Because there are some people who think that I can make them laugh. They are actually not teachers, they are jokers. No content at all. They will just make fun. But you can make fun, but the content should be good. So always, the subject should be relevant. Now, if I am talking about anatomy today, I shouldn't be talking about some Timbuktu. I should be talking only about anatomy. It should be relevant. It should be clinical anatomy at the most, surgical anatomy. It can be radiology, but anatomy should be there when you talk. Enjoyable, of course. Without enjoyment, it becomes sleep-inducing lecturalgia. Very painful. You can't sit also, you can't stand. If you stand, why are you standing in the middle of the class? My sciatic nerve is damaged sitting, listening to you. I'm falling asleep. But what I do is, every 20 minutes, actually I should ask all of you to stand and do jumping jacks. Stand up. Nobody is standing because I'm not your teacher. But in first MBBS you can do that. You can activate their mode or ask them some questions. So make it a little enjoyable for the student. Now came the overhead projector. How many people have used this? OHP. Yes, we all have used it. 1995 onwards, OHP. And all transparencies, dark room. Some of the students were enjoying. You didn't know what was happening. And your transparency is also very bad. You are drawing it. But this went on, because if you don't use OHP, you are not good for nothing. I had such a big bundle of OHPs, which I threw out recently because it was gathering some dust. But some people know they are very sentimental. They will keep it. OHPs are out of circulation. Don't use it. We have got now the other ones where the transparency is not there, but you can attach your camera or your cell phone, and you can still use the projector. PowerPoint presentation. With that, I may hurt some people's sentiments here. I'll tell you the reason. Is it the best visual aid is number one question. Power. Point. Presentation. Next slide I would like to show. PowerPoint slides are like children. No matter how ugly they are, you will think they are beautiful if they are yours. So let me go back now. Power corrupts. PowerPoint has corrupted all of us, because when we were dependent on chalk and board, we at the most used to have a small slip. We used to be completely prepared for the class. Now, who is powerful? PowerPoint projection. But the PowerPoint tells us each point should be powerful. It should not be in a whole sentences, because sometimes PowerPoint presentation is like, I can say that Indian weddings, big fat Indian weddings. Nowadays everybody dresses up, bride's mother, bride's father, bride, guests. So you don't know who is the bride. You are confused. So sometimes our PowerPoints are such that it is like big fat Indian wedding. You don't know whether you have to listen to the lecturer. That person is thinking, I am talking, everybody is listening. And what to read? So the word PPT says that each point should be powerful. The power is with whom? With the lecturer. You have to be powerful. Who is the best visual aid? You. You are the best visual aid. Do not misuse PowerPoint presentation. It bores you to death. You may be thinking, I used PowerPoint. Mine was the best. For that I told you the next point. Now came the 2020. You know what it is? All of you were not wearing pants, only shirt with the shorts or a coat with the shorts. Your cat was playing around. You are sitting at home and trying not to appear on the screen, and you used to use the mantra, am I audible? Are you there? Can you see my PowerPoint? These are the three things you have to say, then start. Imagine lecture can be so boring. What would have happened to the students on online lectures? They were not there. You were there because you are paid the salary, even if sitting at home, eating charmuri in between and talking. Okay, you are not combed your hair. You are sitting in your bedroom in your night dress and you are taking the class. And they will appoint one person, one student. Whenever the teacher, are you there? That person, yes, madam. Then he'll say, next half an hour, you answer. Some of them are lying down also. We didn't know what was happening. That was 2020. And moreover, in 2019, the NMC is telling have small group teaching. It was small group only because nobody was listening to you. Okay. So what is this? Microsoft Teams. So those who have done all this, they know. Because these were the teams we were using to talk to the students. They took upper hand. Zoom. Yes. Now we are all well versed because of you should be thankful to Corona God. Because we became smart. We became savvy. Only because otherwise we wouldn't have mastered all this. Other than some lives which I have lost, which I am very sorry for, those who sat at home who are very safe have learned a lot. I am just talking about the evolution. This was the picture before. Now later it became this. See the picture again. Renaissance picture. Only thing is they are visible. Our students are not visible. They are not there. Okay. This is what a major evolution which has happened. I tell you, when you talk about evolution in medical education, happened in 2020. Not before that, according to me. Maybe sir will ask me some questions. Okay. And there were some Zoom fails. Somebody was changing the nappy. Or you know, one of the CEOs, his wife became very romantic and came and kissed him on the cheek. And his entire employees saw that. His wife only, luckily. So all these are called as Zoom fails. So all these things have happened. And many people forgot that they are wearing a coat on the top, shorts at the bottom, and suddenly they forgot to switch off the video and they got up. And their employees had a great time. So all these fails also happened. There are a lot of humor in this. Of course, the bombardment of social media happened maximum after 2020. YouTube, so many budding YouTubers. Do you know who are the best anatomy teachers now? Our students. They are in YouTube. Ladies who are sitting at home, housewives, making kosumbari, and they are calling it an amalgam of vegetables in dal and flavored Indian spices, that is sambar. Okay? They have got millions of followers. And the students are smarter than us. They are techno-savvy. Do you know they have got classes going on? They have got algorithms. Particular Monday, Tuesday, Wednesday, if you go, there is a student who teaches anatomy in a very easy way. Facebook, YouTube, Instagram. Now, what I tell you is, okay, we wear a sari and pose. I am in Dharwad, KCACON. But I am telling you, you have the content. You can make YouTube channels. So that is the latest one because we have got dearth of cadavers. You can videograph the dissection and show the students. You can progress in certain ways. So the social media, I can say, has the greatest impact and all students are coming to the class because of social media. Why? They'll put it on silent. They don't disturb you. They don't talk. So they will not, because it has helped us actually. They won't disturb us. Now the student-centric learning, level 3, we have got problem-based learning. I'm not going into the details of that. It only facilitates solving a problem, not coming to a complete conclusion. In problem-based learning, you have a brainstorming session, students put in their ideas, you stand there and watch, and sometimes they go somewhere parallel, then you have to drag them back. So you become the facilitator. Case-based learning, that also is the latest one. You can use these case studies. Flipped classrooms. So I would like to talk about, and nowadays they call as student can have their electives. I tell you, 9 months of anatomy, what all you can do, circus. Okay? So this is the problem-based learning, small group teaching, like yesterday's tables. You might have solved a lot of problems yesterday. Sitting with a glass of wine or so many problems we solved yesterday. So that was actually problem-based learning which went on yesterday. Flipped class, we are happy. You tell them, see, on Monday, I am taking thyroid gland. These are the sites you can go and find out what thyroid gland is. You come prepared and you go home and lie down. That is flipped class. Students have to do all the struggle, but it is good for the staff members, but you should be very knowledgeable to do that because you have to guide them. Now comes the bolt from the blue, the AI 2023. I will call it as Aladdin's Chirag. Every time because we are also AI facilitated. You know what is there in Google? Nowadays you got AI mode. What do you call it? Gemini. You go to WhatsApp, you got Meta AI. We are already, and you go to one website and look at a particular chudidar. Next 15 days it will be bombarding you with the same photo. Because every media you are going there, so be careful. What you are feeding into the computer, what you look into, you think, secretly I will sit and look at this. But there is an AI there. So next time is, do you want to see this? Then you have to beg it. Please don't. I had enough of seeing this churidar for the 100th time. I am tired of this ad. So everywhere there is AI, and in our institution they are given us Copilot. Copilot is there. It is actually it is beautiful. You can make all these CBLs using that. And nowadays I feel all these interactive sessions or the teacher training programs, they should be based on AI. We have to get trained because our students already know it. They are much better than us. And that means, I said, Aladdin ka chirag. Everybody has it. And that will come, kya hukum hai haka? It will ask. And you ask questions. And it will answer for you. But don't believe it. Because if you give wrong questions, it will give you some misleading answers. So, finally it depends on you. Now all are supermen. Because everybody has got this artificial intelligence going on. From where did that intelligence came? You fed the computer. So these people who are very clever joined all your intelligence and created these tools. But what you ask, you have to be very, very careful. And if you have got some patent or some ideas, never ask it. Because it will tell that to somebody else. But what I have learned from AI is, some emotional things I have learned. It is very emotionally competent also. You can write, I felt very bad at your answer. I didn't expect that. It will not get angry. Now suppose when you talk to human beings, we ask 2 questions, they will take it. 3rd question, what do you want? We get angry, isn't it? When we teach our children also at home. AI is very cool. Ask it 1,000 times. It will come with different answers. And AI has become generative AI. It can generate images. It is very good for anatomist. It has become multimodal. Because in clinical side, if you have a multimodal AI in your clinics, it will write the clinical notes for you. It will listen to what you are talking to the patient, what you are doing. So it sort of surrounds you, this multimodal AI, and it will make your work easy. Mundane work, we say. Mundane work is, taking down logbook, student assessment, but never give them assignments. They will also go to Copilot. Copilot, create these notes for me. Patakka, he will send it to me, my student. He has not even read it. So assignments you should not give, but some of the work which you do in the department, you can use AI. Advantage is, virtual dissection and simulation is AI based. Personalized learning path, that means it depends on your level of learning, it will modify. Complex area visualization like middle ear or pterygopalatine fossa or deep part of the infratemporal fossa, you can use this AI and it can reach all these remote places, and it will also give you the methods of innovative assessment methods. So if you find that your HOD says, no, this time the assessment has to be innovative, and she goes and sleeps. So what do? You go to AI, you go to Copilot, see the topic is this, respiratory system. What are the innovative assessment you can do? Or you have to write an abstract. You just write your topic. I have to, sorry to say, Veena madam, write your entire presentation in 250 words. I used AI. She wanted it today. I put the entire thing, then I saw. But you have to assess it, whether it has written properly. Once it is in sync with your thoughts, send it. You can form letters, all these things. Disadvantage is over-reliance on technology. That is one thing. And the human interaction becomes less. So the cadaveric dissection, the chalk and board teaching, still it should go on. So what we should do, what all of us should do. Now let us come to artificial intelligence is no match to natural stupidity. So you also have to be intelligent to interact with the artificial intelligence. Now conclusions, it mainly depends on the regulatory bodies because NMC comes with all new colors every year. This year you do this. You have to do vertical integration, horizontal integration. You have to call somebody, early clinical exposure. In those premature delivery, so many other things are added. So you don't know. And you feel best is I take a lecture, I finish it off. Okay? Second is, subject in question. Anatomy is a tough subject. You cannot apply all the technology. I can say, all of us, juniors or seniors, we have to be technologically sound, if not savvy. We should know what others are doing, not that you have to, break your, I don't know what is AI is. At least know something about it and you should know how to catch them. Student strength, 250 students, small group teaching, how many lecture halls you have? What arrangements you have? What demo rooms you have? We have to look at the student strength, faculty. Now I feel that anatomists are kings and queens. Everywhere you go, they call you up. Madam, are you interested to join our institution? And they will show the red carpet also. They will also show what are the emoluments they are going to give. So the future students, this is one indication, take up MD anatomy and come and relieve us. Because otherwise, they may increase our retirement age to 80 years. And after another 20 years, I will come. Today, I have learned this because there are no other teachers. So dearth of faculty, faculty development programs. Let us more concentrate on the next batch coming. What is that batch? Gen Alpha. Let us be prepared for that and try to improve our infrastructure, make it more technologically sound. You need not be too savvy, but let each institution be technology. With that, I finish I hope I have come to the end of evolution. So thanks also has evolved. Thank you became thanks, then THX, then thank you. So there also I have evolved in my thank you. Thank you very much. Hope you didn't have entertainment program last time. I gave you.
We extend our sincere gratitude to Dr. Lata V. Prabhu Madam for that enlightening and reflective discourse. Her scholarly presentation on the evolution of teaching methodologies in human anatomy has offered both depth and direction to our ongoing pursuit of excellence in medical education. May I request distinguished chairpersons and Dr.
Sorry, no, ma'am. No, ma'am.
No, if anybody is having questions.
Session is still open
Still
for
open.
question. Yes, we're sorry
Madam,
for that.
thank you. It was a very nice audience-centric presentation. I'm here, ma'am. Thank you. And I would like to share that yes, we are following the traditional teaching with the dissection table, and each dissection table we have 5 blackboards and make the students to draw. But at the same time, we also have large group teaching where we have 3Ds and virtual teaching, where the student expect us to close the lights. And we also immediately we on it and see the mobile flash on their face. This is what it is.
Yeah,
there.
that's what I said. Finally, the best visual aid is the teacher. Cadaver is the first teacher. You can never, know anything technology comes, dissection still stays. It is a beautiful way of learning. And they're telling some of the departments of medicine do not need anatomy. Are Marai re, you are working on one machine, human body. You have to know basics of the human body because your entire career is on this human body. So everybody has to know basic anatomy. Anatomy will always remain. However, the teaching methodology may evolve. We will go on. Okay? We will go on. Our dissection will go on. Our tradition will go on. It cannot replace. No modern method. Maybe for research, we can use modern methodologies. My conclusion is that we should be balanced between the tradition and the technology. Thank you, ma'am.
Thank you, ma'am.
Any other questions if you have? We can have some more entertainment. It is almost 12:30. I think time is up. Thank you very much.
Thank you, ma'am.
May I request distinguished chairpersons and Dr. Veena madam to kindly give away the token of gratitude to Dr. Lata Prabhu madam. We also take this opportunity to place on record our deep appreciation to the esteemed chairpersons, Dr. Meenakshi Parthsarathi and Dr. S.K. Deshpande sir, for their distinguished presence and for conducting the session with a remarkable academic grace and precision. May I request Professor Dr. Veena Kulkarni madam to kindly give away the token of gratitude to the respected chairpersons.
Thank you, ma'am. Thank you, sir. As we conclude this morning's academic journey, we are reminded once again of the immense value of continued learning, the wisdom of our mentors, and the evolving horizons of anatomical science. Let us take a moment to thank all the orators and the chairpersons who have added immense depth to today's program. Their contributions are not only academic, but truly inspirational. Thank you so much. So, before we proceed for the valedictory function, I request the delegates to kindly remain seated. And I would also like to thank the sponsorship given by the Trivitron company. Our heartily thanks from the organizing team. There's a short video clip that will be played.
Kindly note, delegates, valedictory function will start in a few minutes, so kindly be seated in the auditorium. Thank you. Following the valedictory function, the lunch will be starting at the ground floor of the Kalakshetra. Please join for the lunch also. Thank you.
While AI-generated images impact many industries, they remain limited to external appearances. Anatomoge, on the other hand, delivers the most comprehensive, medically accurate, and visually stunning real human inner anatomy. This innovation is transforming how we understand and appreciate medical science. Over the years, Anatomoge has continuously improved its cadaver digitization technology, overcoming numerous challenges associated with constructing 3D models from frozen cadaver data. Anatomoge has significantly refined its visuals, ensuring that while maintaining the precision of real cadavers, the models have been dramatically enhanced in several key areas, from visual noise to smoother surface textures, eliminating distortions for a clearer, more detailed view. From missing details to more pronounced muscle fibers, providing a deeper understanding of muscular structure. Complete bronchial details, showcasing every branch of the respiratory system with high precision. Accurate vascular details, fully tracing arteries and veins to ensure an interconnected and functional cardiovascular system. Retention of original volumetric integrity, ensuring that the models accurately reflect the true shape and volume of anatomical structures. The result is a highly convincing anatomical model. The shapes are as accurate as those found in real cadavers, with surfaces that are perfectly separated for clear visualization. Ligaments and vascular connections are replicated with exact precision, offering an unmatched level of anatomical detail and realism. Anatomoge bodies offer convenient, preparation-free dissections, allowing students to practice repeatedly without worry of mistakes, boosting knowledge retention. Anatomoge's advanced inner anatomy visualization is revolutionizing medical education, offering students an unparalleled understanding of human anatomy. Learn more about these revolutionary advancements at anatomoge.com/table. Anatomoge, advancing medical advancements through digitized cadavers.
For most of my career, I've really spent time teaching sort of upper level undergraduate students and master's level students. And so coming here to the School of Health Professions was a new thing for me and a bit of a challenge in a couple of ways. One of the ways was just trying to learn about what I needed to teach physician assistant students, and I'll talk a little bit about that. And then the other thing is learning how to use the Anatomoge table. St. Bonaventure is a relatively small private Franciscan university, and so this is the building that we're in, Francis Hall. You can see we're out in the middle of the trees, really. And this is a building that was originally built back in the 1950s as a friary for the Franciscan priests or Franciscan friars who were training here. And then in 2017, they started a new School of Health Professions. And that school is in a completely renovated building that we're in, and includes a couple of master's programs, one in physician assistant studies, the other one in occupational therapy, and then a number of undergraduate programs, including health science, students, public health. There's also should have put under the master's, also a master's of public health program that's going to be starting soon. This is the virtual anatomy lab that we have for our students, and so you can see there's a couple of sides. There's one side here, and then it's separated by a partition, and there's another side. If you look back here, you can see that for each table, we do have a high-resolution flat screen that we can plug in with an HDMI cable. We're going to have, when we're completely full, about 40 students in a class, and so what I've been doing is breaking them into small groups, so a little bit bigger than this. We usually work in groups of 5 to 6 students. And so one of the things that's really great about these tables is they're very interactive. Students can work quite independently. And the other thing that I've noticed is students teach one another. And so you could think of this, if you think of it sort of formally, this is something that could be called peer-led team learning. They're working as a team to learn the material, and they can come up with their own insights. And one of the things that I'll show you is how I use quizzes to get them to interact with the tables. And oftentimes, as I'm walking around fielding questions and that kind of thing, I can see that the students are helping out one another, you know, reminding them of where a structure is or correcting them or giving them suggestions. And so that works really well. So what I'm going to start with as an example is the hepatic portal system. And so one of the things that I discovered the last time that I was teaching the GI system was that students were having some confusion about the difference between the hepatic portal vein and hepatic veins. And so there's a complex relationship that's really important that they understand. So it's not just simply identifying structures and naming them, but they need to understand that the principles here that are involved. So what I've done here with this preset, so this is again just a screen capture of a preset that I built, is here you can see the hepatic portal vein, and then here are vessels that lead into that. And so we'll talk a little bit about that. So the first thing I have to do with students is, again, think about things conceptually or functionally. What is a portal vessel? So the hepatic portal system is one example, maybe the most dominant example of a portal system. So a portal system is basically a vessel that's connecting two capillary beds. And so this is different, of course, from what we think of traditionally as, you know, within a systemic arterial and venous system to an organ, because you're not going back to the heart between the venous side and the arterial side. So it's directly connecting one capillary bed to another capillary bed without going back to the heart first. So the hepatic portal vein basically connects the intestinal capillaries with the capillary system within the liver sinusoids. And so again, this is kind of a direct route for delivering the blood from the GI system into the liver and forcing it through the liver before it goes back to the systemic circulation. So here again is the hepatic portal system. I've highlighted the hepatic portal vein there in blue so that you can see it. And then basically, if you think about the direction of blood flow, it's coalescing or bringing all the blood from the GI tract directly into the liver. And then one of the things I can do with the anatomized tables very quickly is just I've added the liver. One of the things you'll notice is that it's semi-transparent. So you can see the location of the liver, the orientation of the hepatic portal vein, and really spreading through the liver, perfusing that. But you can see the vessels inside the liver. Again, if this were on the table, you can spin it around three-dimensionally. You can pan up and see things very closely. And so this is one of the images that I might set up for the students and just let them explore that a little bit. The other thing just to mention too, if you haven't used the tables, is if you touch, you know, the tables are basically sophisticated touch screens. If you touch any of these images, it will immediately come up and tell you what the structure is. So students are able to learn on their own and really explore and see how things are arranged. So the liver is really the place where the blood is going to. Where is it coming from? So here I've just added the small intestine. So here you can see the duodenum leading into the jejunum and the ileum. So it's coming from the small intestine. It's coming from the colon. So there you can see the large intestine starting with the cecum. It's also bringing blood or draining blood from the stomach and the pancreas, also the spleen, which is here. I haven't added that on. And so all of the blood coming from those organs is going into the liver. So the next thing that you really have to think about conceptually, and one of the things that I do with my students, is to get them to think about, well, why the liver? And so the liver is basically, you know, the major metabolic organ of the body. And so the nutrient-laden blood that's coming directly from the GI tract is going directly to the liver so that it can decide, so to speak, what to do with all of the nutrients, what to do with the sugars like glucose, what to do with the amino acids, what to do with iron, those kind of things. The other thing is that there's potentially bacteria coming from the gut into the cardiovascular system. And so if you actually could culture some of the portal blood coming from the gut, it would actually grow bacteria on a plate. And so one of the things that the liver is also doing is that there are fixed macrophages, the so-called Kupffer cells, that are getting rid of those bacteria. So actually one of the things that I use on the tables, and I'll just mention here in addition to the sort of gross anatomy, is that well, first of all, the tables have histological slides that you can access. Here's a histological image, a drawing from a textbook, and so it's important to understand the histological organization of the liver. So again, here's the periphery of the lobule, and this is the direction that blood flows. So it's really being forced through all of those hepatocytes through the sinusoids. So here, if you can see in sort of blue, I've added the hepatic veins. So again, students are sometimes confused and perplexed by the difference between hepatic veins and the hepatic portal vein. So here's the hepatic portal. It's not highlighted, but here you can see that the hepatic veins go back into the inferior vena cava. So here is where the heart would be. This is the superior vena cava. And so you can illustrate, and you can use different colors to highlight that. Here I've highlighted the hepatic veins in blue, and I can show the hepatic portal in white. And so then students can see that in this area, essentially what we're not seeing are the capillaries that interconnect the hepatic portal vein back to the hepatic veins. So there I've illustrated some different things. I set these up as presets. If you've used the tables, you know that this little icon down here, the 1, 2, 3, is where you click to bring up the window for the presets. Here you can see
ದಯವಿಟ್ಟು KCA ಎಲ್ಲ ಪದಾಧಿಕಾರಿಗಳು ವೇದಿಕೆ ಮೇಲೆ ಬರಬೇಕು, ಹಾಗೂ ಆರ್ಗನೈಸಿಂಗ್ ಕಮಿಟಿ ಎಲ್ಲರೂ ವೇದಿಕೆ ಮೇಲೆ ಆಸೀನರಾಗಬೇಕು ಅಂತ ಕೋರ್ತಾ ಇದ್ದೇವೆ. ಹಿಂದೆ ಕೂತವರೆಲ್ಲ ಮುಂದೆ ಬರಬೇಕು. ಫ್ರಂಟ್ ಬನ್ರಪ್ಪ, ಎಲ್ಲರೂ ಬರ್ರಿ. ಆಲ್ ಸ್ಟೂಡೆಂಟ್ಸ್ ಪ್ಲೀಸ್ ಕಮ್ ಫ್ರಂಟ್. ಬನ್ನಿ, ಮುಂದ್ಗಡೆ ಬನ್ನಿ ಪ್ಲೀಸ್.
But then you can export that whole set.
Come front, please.
Save them either on the table or
Bunny, please come.
to an external hard drive, and there you have them saved, and students can use them as they want to.
Dr. Ashwini madam,
So the last
Meenakshi
thing
madam.
I will talk about how I've used practicals. So for our students to do assessment, they are tested on this material, and so one of the things that I've done is learned how to use the tables to set up lab practicals, which is really, I think, a very effective way of testing their knowledge. So, a traditional lab practical like most of us has probably done.
Sir, please.
You spend hours and hours either sorting through different cadavers or different specimens, getting them laid out and positioned so that you can see specific structures and that kind of thing, and then physically putting pins in the structure that you want to identify. Well, there are virtual pins on the table, and you can see what I typically do is I lay them out.
Please come front, please.
3, 4, 5, from left to right. This is just simply a preset, and so once I have my presets put together, I can just pull this up, and students can go through and identify the structures. Again, the nice thing about this is that you can pan up, you can really get in close magnification, you can spin the cadaver, you can move it in any kind of a direction you want, and students then answer those questions. It takes a little bit of practice if you haven't done it, but you can learn pretty quickly how to get those pins in place. The thing that's really cool is once they're in place, it really looks like they're virtually stuck through the structure. So if you look up here and you can see the jugular vein that I've highlighted in blue, if you look closely,
ದಯವಿಟ್ಟು ಎಲ್ಲ ಆರ್ಗನೈಸಿಂಗ್ ಕಮಿಟಿ ಮೆಂಬರ್ಸ್ ಮತ್ತು KCA ಎಕ್ಸಿಕ್ಯೂಟಿವ್ ಕಮಿಟಿ ಅವರು ಮುಂದ್ಗಡೆ ಬರಬೇಕು. 25th KCACON 2025ನ ಸಮಾರೋಪ ಸಮಾರಂಭವನ್ನು ಆರಂಭ ಮಾಡ್ತಾ ಇದ್ದೀವಿ. ಈ ಕಾರ್ಯಕ್ರಮದ ಅಧ್ಯಕ್ಷತೆಯನ್ನು ಡಾಕ್ಟರ್ ಅಶ್ವಿನಿ ಅಪ್ಪಾಜಿಯವರು ವಹಿಸಲಿದ್ದಾರೆ. ದಯವಿಟ್ಟು ವೇದಿಕೆಗೆ ಬರಬೇಕು ಮೇಡಮ್. ಅದೇ ರೀತಿಯಾಗಿ ನೂತನ ಅಧ್ಯಕ್ಷರಾಗಿ ಅಧಿಕಾರ ಸ್ವೀಕರಿಸಲಿರುವ ಡಾಕ್ಟರ್ ವೀಣಾ ಕುಲಕರ್ಣಿ ಮೇಡಮ್ ಅವರು ವೇದಿಕೆಯನ್ನು ಅಲಂಕರಿಸಬೇಕು ಅಂತ ಅವರಲ್ಲಿ ಕೋರ್ತಾ ಇದ್ದೀವಿ. ಅದೇ ರೀತಿಯಾಗಿ ಈ ಒಂದು ಸಿಲ್ವರ್ ಜುಬ್ಲಿ ಸೆಲೆಬ್ರೇಷನ್ ಕಮಿಟಿ ಅಧ್ಯಕ್ಷರಾಗಿ ಅಭೂತಪೂರ್ವ ರೀತಿಯಲ್ಲಿ ಕಾರ್ಯಕ್ರಮವನ್ನು ಸಂಘಟಿಸಿದ ಈ ಆರ್ಗನೈಸಿಂಗ್ ಕಮಿಟಿ ಚೇರ್ಮನ್ರಾದ ಡಾಕ್ಟರ್ ಮೀನಾಕ್ಷಿ ಮೇಡಮ್ ಅವರು ವೇದಿಕೆಗೆ ಬರಬೇಕು ಅಂತ ಆಹ್ವಾನಿಸ್ತಾ ಇದ್ದೀವಿ. ಅದೇ ರೀತಿಯಾಗಿ KCA ಎಲ್ಲ ಎಕ್ಸಿಕ್ಯೂಟಿವ್ ಕಮಿಟಿ ಮೆಂಬರ್ಸು ದಯವಿಟ್ಟು ವೇದಿಕೆಗೆ ಬರಬೇಕು. ಬನ್ನಿರಿ ಮೇಡಮ್. ಹೇಳ್ತೀನಿ ಫಸ್ಟ್ ಇವ್ರಿಗೆ. ಹಲೋ ಪರಶುರಾಮ್ ಹೇಳ್ರಿ. ಎಲ್ಲ ಎಕ್ಸಿಕ್ಯೂಟಿವ್ ಕಮಿಟಿ ಮೆಂಬರ್ಸ್ ಬರ್ರಿ ದಯವಿಟ್ಟು. ಅದೇ ರೀತಿಯಾಗಿ ಈ ನಮ್ಮ ಸಂಸ್ಥೆಯ ಬೆಳ್ಳಿ ಹಬ್ಬದ ಈ ಸಮಾರಂಭವನ್ನು ಅತ್ಯಂತ ಸುಸಜ್ಜಿತ ರೀತಿಯಲ್ಲಿ ಅತ್ಯಂತ ಸಂಶೋಧನಾತ್ಮಕವಾದಂತಹ ಚಟುವಟಿಕೆಯನ್ನು ನೀಡೋದರ ಮೂಲಕ ನಾವು ಏನು ಬೆಳ್ಳಿ ಹಬ್ಬವನ್ನು ಆಚರಿಸಬೇಕಂತ ಮಾಡಿದ್ವಿ ಆ ನಿಟ್ಟಿನಲ್ಲಿ ಅತ್ಯಂತ ಶೋಭಾಯಮಾನವಾಗಿ ಈ ಒಂದು ಕಾನ್ಫರೆನ್ಸನ್ನು ಮಾಡಿಕೊಟ್ಟಂಥ SDM ವಿಶ್ವವಿದ್ಯಾಲಯದ ಎಲ್ಲ ಆಡಳಿತ ಮಂಡಳ ಸದಸ್ಯರಿಗೆ ನಾವು ಧನ್ಯವಾದಗಳನ್ನು ಅರ್ಪಣೆ ಮಾಡ್ತೀವಿ. ಈ ಕಾರ್ಯಕ್ರಮದ ಸಂಘಟನೆ ಬಗ್ಗೆ ತಮ್ಮ ಅಭಿಪ್ರಾಯಗಳನ್ನು ಹೇಳಬೇಕು. ಮೊಟ್ಟ ಮೊದಲನೇದಾಗಿ ಡಾಕ್ಟರ್ ಸಂಜೀವ್ ಕೊಳಗಿಯವರು ಬಂದು ಈ ಕಾರ್ಯಕ್ರಮದ ಬಗ್ಗೆ ತಮ್ಮ ಒಂದೆರಡು ನುಡಿಗಳನ್ನು ಹೇಳಬೇಕು. ಇಲ್ಲೇ ಬರ್ರಿ, ಇಲ್ಲೇ ಬರ್ಬೇಕು, ಕೆಳಗಿಲ್ಲ. ಇಲ್ಲೇ ತಿಡ್ರಿ ಮೈಕ್.
It was a very nice conference and Silver Jubilee function. The topics selected for oration and guest lectures were the best and very enlightening for us. Thank you the organizing team for selecting such a wonderful people for presenting their oration and lectures. Usually conferences are not for learning. That was a tradition. Now the things are changing. We learned a lot from a lot of people around here. Thank you, Veena, for taking all the initiative and making it wonderful. Thoroughly enjoyed. That's the word for it. So thank you. I request even Mahesh sir to say something.
So as Sanjeev told, ಎಲ್ಲರಿಗೂ ನನ್ನ ನಮಸ್ಕಾರಗಳು. ಆ್ಯಂಡ್ SDM ಕಾಲೇಜ್ ಸ್ಟಾಫ್ಗೆ, ಕೆಲಸ ಮಾಡಿದವರಿಗೆ ಎಲ್ಲರಿಗೂ ನನ್ನ ವಂದನೆಗಳು. ಅದ್ಭುತವಾಗಿತ್ತು ಕಾನ್ಫರೆನ್ಸು. ಇಷ್ಟು ಕಷ್ಟ, ಇದು ತಮಾಷೆ ಮಾತಲ್ಲ, ಒಂದು ಸ್ಟೇಟ್ ಲೆವೆಲ್ ಕಾನ್ಫರೆನ್ಸ್ ಎಲ್ಲ ಕಂಡಕ್ಟ್ ಮಾಡೋದು. ನಿಮ್ಗೆಲ್ರಿಗೂ ನನ್ನ ನಮಸ್ಕಾರಗಳು. ದೇವರು ಒಳ್ಳೇದು ಮಾಡಲಿ.
ಡಾಕ್ಟರ್ ಸುರೇಶ್ ಮನಗುತ್ತಿ, ಜಾಯಿಂಟ್ ಆರ್ಗನೈಸಿಂಗ್ ಸೆಕ್ರೆಟರಿ ಅವರು ವೇದಿಕೆಯನ್ನು ಅಲಂಕರಿಸಬೇಕು. ಬರ್ರಿ ನೀವು ಫಸ್ಟ್. ಡಾಕ್ಟರ್ ಅವ್ರು ಬಾ ಅಂತ ಹೇಳಿದಾಗಲಿ. ಡಾಕ್ಟರ್ ನಾಗರಾಜ್ ಭಟ್ ಸರ್, ಅಲ್ಯೂಮಿನಿ ಆಫ್ SDM, ಫಸ್ಟ್ ಬ್ಯಾಚ್ ಸ್ಟೂಡೆಂಟ್. ಯಾರಾದರೂ ಲೇಡೀಸ್ ಮಾತಾಡ್ರಿ ಮೇಡಮ್. ಔಟ್ಸೈಡ್ ಕರ್ನಾಟಕ ಯಾರು ಇದ್ದೀರಾ? ಸ್ಟೂಡೆಂಟ್ಸ್ ಕೊಡ್ರಿ. ಅಲ್ಲಿ ಒಬ್ರು ಯಾರು ಒಬ್ರು ಸ್ಟೂಡೆಂಟ್ ಮಾತಾಡ್ತಾರೆ, ಕೊಡ್ರಿ ಅಲ್ಲಿ ಹೋಗಿ. ಮಾತಾಡಲೇಬೇಕು, ಇಲ್ಲಾಂದ್ರೆ ಸರ್ಟಿಫಿಕೇಟೇ ಕೊಡಲ್ಲ.
Good afternoon, everyone.
ನೀವು ಬರ್ರಿ ಮೇಡಮ್, ಇಲ್ಲಿ ಕೂತ್ಕೋರಿ.
Myself, Dr. Rafiq from Kerala, Malabar Medical College. So I attended this conference. It was an opportunity as Dr. Vinay sir, he was my senior and I inquired. I'm very thankful to you all to give a chance to attend this wonderful event. And the most excited thing is the campus and the venue, which we like most. And we are thankful to you. We are expecting more to explore even from Kerala, Tamil Nadu and other states, because KCA conferences are always unique. I had attended earlier also. Thank you everyone for this.
ಸಂಸ್ಥೆ 25 ವರ್ಷಗಳ ಈ ಒಂದು ಬಹುದೊಡ್ಡ ಸಾಧನೆ ನಿಟ್ಟಿನಲ್ಲಿ ಈ ಬೆಳ್ಳಿ ಹಬ್ಬದಂದು ನಮಗೆ ಮತ್ತೊಂದು ಖುಷಿ ಸುದ್ದಿ ಬಂದಿದೆ. ನಮ್ಮ ಕರ್ನಾಟಕ ಅಂಗರಚನಾಶಾಸ್ತ್ರ ಒಕ್ಕೂಟದ ಅತ್ಯಂತ ಗೌರವಾನ್ವಿತ ಸದಸ್ಯರಾದ ಡಾಕ್ಟರ್ ಮಮತಾ ಅವರಿಗೆ IMA ಕರ್ನಾಟಕ ಘಟಕದಿಂದ ಬೆಸ್ಟ್ ಎನಾಟಮಿ ಟೀಚರ್ ಅವಾರ್ಡ್ ಬಂದಿದೆ. ಅವರು ದಯವಿಟ್ಟು ವೇದಿಕೆಗೆ ಬಂದು ನಮ್ಮ ಗೌರವವನ್ನು ಸ್ವೀಕರಿಸಬೇಕು. ಅವರನ್ನು ನಮ್ಮ ಸಂಸ್ಥೆ ಪರವಾಗಿ ನಮ್ಮ ಅಧ್ಯಕ್ಷಣೀಯರಾದ ಡಾಕ್ಟರ್ ಅಶ್ವಿನಿ ಮೇಡಮ್ ಅವರು ಹೂಗುಚ್ಛವನ್ನು ನೀಡುವುದರ ಮೂಲಕ ಅವ್ರನ್ನ ಗೌರವಿಸಬೇಕು ಅಂತ ಕೇಳ್ಕೊತಾ ಇದ್ದೀವಿ. ಡಾಕ್ಟರ್ ಮಮತಾ ಅವರು ಇಂಡಿಯನ್ ಮೆಡಿಕಲ್ ಅಸೋಸಿಯೇಷನ್ನ ರಾಜ್ಯ ಘಟಕದಿಂದ ಬೆಸ್ಟ್ ಟೀಚರ್ ಅವಾರ್ಡನ್ನು ಪಡೆದಿದ್ದಾರೆ. ಕೆಲವೇ ದಿನಗಳ ನಂತರ ಚಿತ್ರದುರ್ಗದಲ್ಲಿ ನಡೆಯುತ್ತಿರುವಂಥ ಸಮಾರಂಭದಲ್ಲಿ ಅವರು ಪ್ರಶಸ್ತಿ ಸ್ವೀಕರಿಸಲಿದ್ದಾರೆ. ಅದೇ ರೀತಿ ಅವರು ಕೆಲ ದಿನಗಳ ಹಿಂದೆ IFAA ವರ್ಲ್ಡ್ ಕಾಂಗ್ರೆಸ್ಸಿನಲ್ಲಿ ಸಹಿತ ಬೆಸ್ಟ್ ಯಂಗ್ ರಿಸರ್ಚರ್ ಅವಾರ್ಡನ್ನು ಗೆದ್ದಿದ್ದಾರೆ. ಅವರಿಗೆ ನಮ್ಮ ಸಂಘಟನೆ ಪರವಾಗಿ ಅಭಿನಂದನೆಗಳು. ಈ ಕಾರ್ಯಕ್ರಮವನ್ನು ಬಹಳಷ್ಟು ಅದ್ಭುತವಾಗಿ ಸಂಘಟನೆ ಮಾಡಿದವರು ಡಾಕ್ಟರ್ ವೀಣಾ ಕುಲಕರ್ಣಿ ಮೇಡಮ್. ವೀಣಾ ಕುಲಕರ್ಣಿ ಮೇಡಮ್ ಒಬ್ಬರೇ ಮಾಡಿಲ್ಲ, ಡಾಕ್ಟರ್ ವಿಜಯ್ ಕುಲಕರ್ಣಿ ಅವ್ರ ಹಿಂದೆ ಅದಾರ ಅಂಥೇಳಿ ಅವ್ರು ಇದನ್ನೆಲ್ಲ ಮಾಡ್ಯಾರ. ಸೊ I thank Dr. Vijay Kulkarni, Principal Sir, for supporting Madam. ಈಗ ಎಲ್ಲರೂ ಹೇಳಿದರು ಸಂಜೀವ್ ಕೊಳಗಿ ಅವರು ಅದ್ಭುತವಾಗಿ ಮಾಡ್ಯಾರ, ಹೆಂಗೆ ಮಾಡ್ಯಾರ, ಅದಕ್ಕೆಲ್ಲ ಮಾಡೋಕ್ಕೆ ಹಿಂದೆ ಸಪೋರ್ಟ್ ಮಾಡಿದವರು ನಮ್ಮ ವಿಜಯ್ ಕುಲಕರ್ಣಿ ಅವರು. ಸೊ ಅವರಿಗೂ ಧನ್ಯವಾದಗಳನ್ನು ಹೇಳ್ತೇವೆ. ವಿಜಯ್ ಕುಲಕರ್ಣಿ ಅವರು ಯಾರು? ವೀಣಾ ಕುಲಕರ್ಣಿ ಅವ್ರ ಹಸ್ಬೆಂಡು. ಗಂಡನವರ ಸಹಾಯದಿಂದ ಮೇಡಮ್ನವರು ಇದನ್ನೆಲ್ಲ ಮಾಡಿದ್ದಾರೆ. ಸರಿ, ಈಗ ಮತ್ತೆ ಯಾರಾದರೂ ಇದ್ರ ಬಗ್ಗೆ ಸರ್, ಈ ನಮ್ಮ ಈ ಸೀನಿಯರ್ ಮೋಸ್ಟ್ ಎನಾಟಮಿಸ್ಟ್ ನಮ್ಮ ಸರ್ ಕೂತಿದ್ದಾರೆ, ಮಾನ್ವಿಕರ್ ಸರ್. ದಯವಿಟ್ಟು ಈ ಪ್ರೋಗ್ರಾಮ್ ಬಗ್ಗೆ ಒಂದೆರಡು ನುಡಿಗಳನ್ನು ಹೇಳ್ಬೇಕು. ಡಾಕ್ಟರ್ ದೇಶಪಾಂಡೆ ಸರ್ ದಯವಿಟ್ಟು ವೇದಿಕೆ ಮೇಲೆ ಬರಬೇಕು. ಎ ವಿ ಕುಲಕರ್ಣಿ ಸರ್ ಪ್ಲೀಸ್.
Organizing a conference is no joke. Our institution has organized national conference way back, state level conference of Maharashtra, recently SOCA also. Organizing is difficult because you will have to keep on doing the routine work, plus you will be doing the conference work. There is nothing like that you are doing conference work and you are put on off duty, no. And there will be so many administrative issues which we will have to assess, and only the organizing secretary will know, which neither she can spell it out nor she can swallow it. And it's not the end. Organizing is one task, disorganizing is other task. Now the actual work of Veena will start now, how to disorganize all the things and get back. So ಮದುವೆ ಮಾಡುವಾಗ ಎಲ್ಲರೂ ಮನೆಗೆ ಬಂದಿರ್ತಾರೆ, ಮದುವೆ ಹೋದ್ಮೇಲೆ ಯಾರು ಇರಂಗಿಲ್ಲ. ನೀವು ಇಬ್ಬರೇ ಇರ್ತೀರಿ, ಮತ್ತೆಲ್ಲ ಆ ಭಾಂಡಿ ಸಾಮಾನು ವಾಪಸ್ ಕೊಡ್ರಿ, ಇವ್ರಿಗೆ ಇದು ವಾಪಸ್ ಕೊಡ್ರಿ, ಅವಾಗ ಇದು ಕೊಡ್ರಿ, ಇದು ಇಬ್ಬರೇ ಮಾಡ್ತಿರ್ತೀರಿ, ಮಂದಿ ಎಲ್ಲ ಹೋಗ್ಬಿಡ್ತಾರೆ. ಪರಿಸ್ಥಿತಿ ಬೇಡ ಅವ್ರದ್ದು ಹಂಗೆ ಆಗ್ತದೆ. ಬಟ್ ಫಾರ್ಚುನೇಟ್ಲಿ ಶಿ ಹಸ್ ಗಾಟ್ ಎ ವೆರಿ ಗುಡ್ ಡಿಪಾರ್ಟ್ಮೆಂಟ್ ವಿಚ್ ಹೂ ವಿಲ್ ಟೇಕ್ ಕೇರ್ ಆಫ್ ದ್ಯಾಟ್. But I must say, right from planning, organization, execution, there was totally flawless. It was flawless. Though there was little delay in the first day, it was not because of them, they were already in the campus, in the hall by 8:30. So there was delay in registration. Usually it happens on the first day. First day, there will be inertia. That's why the moment this thing started, I told her, Veena, beginning is half done. So once it takes off the memento, it goes on its own memento. And the sessions were wonderful, and I should thank Veena for this because she made me to think out of the box for the past 4 months. So when I accepted this topic, it was really a tough topic, and I was not knowing how best I will be able to perform. But I thought that something I must communicate to this young man, and she gave me a wonderful opportunity. For this, I am ever thankful to Dr. This SDM, KCACON, and all the members who made this happen. So, my heartiest congratulations, and for organizing a wonderful conference, especially on Silver Jubilee. I know behind there is always a successful woman, there will be a powerful man. I concur with Bhushan. I concur with me. And I think people understood what I said. Thank you.
Dr. Dundreddy, Professor and Head Kim Jubilee. ಇದ್ರಲ್ಲ ಅವ್ರಿಲ್ಲ ಮಾತಾಡ್ತೀನಿ ಅಂದ್ರಿ. ಡಾಕ್ಟರ್ ಪವನ್ ಹೋಲ್ದಾರ್ ಜಿಮ್ಸ್ ಗದಗ್, ಅಲ್ಲಿ ಕೊಡ್ರಿ. ಕಾನ್ಫರೆನ್ಸ್ ಬಗ್ಗೆ ಹೇಳು, ನೀ ಮಾಡಿಲ್ಲ ಅವ್ರು ಮಾಡಿದವ್ರ ಬಗ್ಗೆ ಹೇಳ್ರಿ ಒಂದು ಸ್ವಲ್ಪ.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. Actually, conference was like a small family conducting very big occasion, and we all enjoyed very nicely. We were ನಮಗೆ ಹೊರಗಡೆ ಹೋಗಬೇಕು ಅಂತ ಅನಿಸ್ಲಿಲ್ಲ. Usually in any conference we just step in, register, take the kit and go. But this is the only conference where we entered, sat till from morning till evening till night, and we enjoyed all the sessions. Thank you for the organizing team. Thank you.
ಅಲ್ಲ ಇದು ಮುಗಿದ ಮೇಲೆ ಹೊರಗೆ ಹಾಕ್ತಾರ, ಹೋಗ್ಬೇಕು ಮತ್ತೆ.
ಅದೇ
ವ್ಯಾಲೆಡಿಕ್ಟರಿ ಮುಗಿದ ಮೇಲೆ
ಹೋಗಲೇಬೇಕಾ?
ಮತ್ತೆ ಯಾರಾದರೂ ಮಾತಾಡ್ತೀರಾ? ಡಾಕ್ಟರ್ ಪ್ರಮೋದ್ ಅಲ್ಲಿ ಕೊಡ್ರಿ, ಹಿಂದ್ಗಡೆ ಅದಾರ ನೋಡ್ರಿ, ಅವ್ರು ಕೊಡ್ರಿ. ದೆನ್ ಡಾಕ್ಟರ್ ಮನೋಜ್ ಅಂಬ್ಲಿ ಫ್ರಮ್ ಕರಾಡ್, ನೆಕ್ಸ್ಟ್ ಕಾನ್ಫರೆನ್ಸ್ ಕಂಡಕ್ಟ್ ಮಾಡೋರು. ಆಲ್ ಇಂಡಿಯಾ ಮಾಡ್ತಿದ್ರಿ, ಹೇಳ್ರಿ ಒಂದು ಸ್ವಲ್ಪ.
ಇಲ್ಲಿ ಕರ್ನಾಟಕ ಚಾಪ್ಟರ್ ಮಾಡ್ತೀನಿ ಅಲ್ಲಿ ಬರ್ರಿ.
ಮಾತಾಡ್ರಿ ಸರ್ ಪ್ಲೀಸ್.
just typing, the time has come to say goodbye to all of you. It was a journey very well organized, academically, all sessions were nice to arrange it. I just missed today Manvikar sir's morning because I rushed to Jubilee, my elder sister is there, she's not well, so I went there, I missed her this one. Thanks to Roshni madam, Deshpande sir, Kulkarni sir, all this are always replying to my messages separately or in the group. Right? So, excellently arranged, academically superb, good food. And what the most thing I feel like coming to the Karnataka conference is that I get talked to in Karnataka, not in Marathi. So that's why I come here and start talking in Karnataka, but I'm not speaking now in the English. Right? Thank you all.
Dr. Pramod.
Good afternoon to everyone. It was a wonderfully organized conference. Last time I remember when Dr. Deshpande sir organized, part of it was a GIMS Gadag conference. We took out many delegates to Gadag to visit and we conducted an anatomy quiz also. I remember the days when we actually hijacked many of these delegates and took them to our not yet built college, and we showed them the DC office and told that this was our college and conducted the quiz. This was actually a very well organized event. We all know that SDM is known for its hospitality. Right from the day one, they took care of every delegate, every student delegates here. I'm astonished to know that many of the first year MBBS who are about to write the exams in 20-30 days are here to present the paper. This just shows that the interest what the teachers are creating among the student faculty and making them to come here and present the papers. I feel that this is the first conference where I am seeing so many undergraduates who have come far away places and they are presenting the papers. And to be frank, when I was a first year MBBS student, I just knew 10% of what they are knowing at present. Their knowledge is tremendous, and the way they are taking and their confidence to present in such a state level conference is astonishing. I thank all their guides and their mentors who have trained them so well. Thanks and hats off to all those teachers. And coming to the organizing team, Dr. Veena madam and all the organizing team, right from Suresh sir, Roshni madam, Kulkarni sir, everyone has contributed. I can understand it's so difficult to organize a conference. In our remote area, Gadag, we organized a state level, and in fact, we can remember it as a global congress of anatomists, if you remember. So it was really worth, and it was a hard work of all this organizing team. Hats off and thanks to all. Thank you.
ಇದು ಸೆಷನ್ಸ್ ಫಸ್ಟ್ ಡೇ ಬಗ್ಗೆ ಹೇಳ್ರಿ. ಫಸ್ಟ್ ಡೇ ಆ್ಯಂಡ್ ವರ್ಕ್ಶಾಪ್ ಬಗ್ಗೆ ಹೇಳಿ.
I was a participant in the problem-based learning workshop, and actually I am into the medical education unit of my institute, and I have completed my BCBR, ACME. Actually, I felt problem-based learning was a bit less covered topic in most of these medical educational unit. So they don't teach it much to that level, how to conduct it for anatomy as per se. So after attending this workshop, Dr. Vijay madam has clearly made us to create how to make a problem, and concept mapping I could correlate with how to frame a concept mapping and how to analyze and how to take the 7 steps. So it was really useful, and myself and Dr. Pawan sir were just discussing that we were going to implement in this next batch coming. Actually, Dr. Chaitra, we want to thank Dr. Chaitra for understanding how the concept mapping was done. She is very good in making this concept mapping, and we would like to take her help also. So to frame these, together we can make these problem-based learnings as a particular case, and we can share it in the group so that we can use it in our own institutions and give repeated feedbacks. So such workshops really help us to improve the teaching methodologies. I really feel that these things to be discussed among those groups what we have created. That will help a lot. And if younger generations could input and give their ideas on these newer methodologies of teaching, like AI and all, so everyone can implement in their own institutions, especially those who are under their medical education units, so they can contribute much, and they can share their knowledges and experiences in improving our own teaching learning methodologies. Thank you.
As Pramod told, first day, Dr. Ashwini CA, Dr. Vasudha Kulkarni, Dr. R. Vijaya, Dr. A. V. Kulkarni, Dr. Asha, Dr. ಸುರೇಶ್ ಬಹಳಷ್ಟು ಅದ್ಭುತವಾದಂತಹ ವರ್ಕ್ಶಾಪನ್ನು ನಡೆಸಿಕೊಟ್ಟಿದ್ದಾರೆ. ಅವರಿಗೆ ಇವತ್ತು ನಾವು ನೆನೆಸ್ಕೋತಾ ಇದ್ವಿ 25ನೇ ವರ್ಷ ಹೆಂಗೆ ಸೆಲೆಬ್ರೇಟ್ ಮಾಡಬೇಕು ಅಂಥೇಳಿ. ಕಾಂತಾ ಮೇಡಮ್ ಅವ್ರು ಭಾಳ ಪರ್ಟಿಕ್ಯುಲರ್ ಇದ್ದರು. ನೀವು ಬೆಳ್ಳಿ ಹಬ್ಬನ ಹಂಗೆ ಮಾಡಬೇಕು ಹಿಂಗೆ ಮಾಡಬೇಕು ಅಂತ. ನಿಜವಾಗಿಯೂ ಬೆಳ್ಳಿ ಹಬ್ಬ ಒಂದು ವಿಶೇಷತೆಯನ್ನು ಈ ವರ್ಕ್ಶಾಪ್ ಮುಖಾಂತರ ನೀಡ್ತು ಅಂತ ಹೇಳ್ಬೋದು. ಆ ಎಲ್ಲ ನಮಗೇನು ಈ ಒಂದು ಅದ್ಭುತವಾದಂತಹ ತಮ್ಮ ರಸದೌತಣ ನೀಡಿದಂಥ ಎಲ್ಲ ಸ್ಪೀಕರ್ಸ್ಗೆ ನಮ್ಮ ಸಂಘಟನೆ ಪರವಾಗಿ ಧನ್ಯವಾದಗಳನ್ನು ಅರ್ಪಣೆ ಮಾಡ್ತಾ ಇದ್ದೀವಿ. ಅದೇ ರೀತಿಯಾಗಿ ಇನ್ನೊಂದು ಮಾತನ್ನು ನಾನು ಹೇಳಬೇಕು. ವಾಲಂಟಿಯರ್ಸ್ ಬಹಳಷ್ಟು ಅದ್ಭುತವಾಗಿ ಕಾಂತಾ ಮೇಡಮ್ ಭಾಳ ಅದ್ರ ಬಗ್ಗೆ ಸ್ಪೆಷಲಿ ಹೇಳ್ತಾಯಿದ್ರು. ಡಾಕ್ಟರ್ ಅಭಿಷೇಕ್ ಅಪ್ಕಮಿಂಗ್ ಡಾಕ್ಟರ್, ಇನ್ನೂ ಡಾಕ್ಟರ್ ಆಗಿಲ್ಲ, ಡಾಕ್ಟರ್ ಅಭಿಷೇಕ್, ಅನಿಕೇತ್ ಆ್ಯಂಡ್ ಕುನಾಲ್, ಸ್ಪೆಷಲಿ ಈ 3 ಜನ ಮಾತ್ರ ಹಗಲು ರಾತ್ರಿ ನಮ್ಮ ಜೊತೆ ಕೆಲಸ ಮಾಡಿದರು. ಅವ್ರಿಗೆ ನಮ್ಮೆಲ್ಲರ ಪರವಾಗಿ ಅನಂತ ಧನ್ಯವಾದಗಳು. ನೀವು ಬುಕ್ಕೆ ಕೊಡ್ಬೇಕು ಅವ್ರಿಗೆ ತಡ್ರಿ, ನೀವು ಆಮೇಲೆ ಮಾಡಿರಿ. ಬುಕ್ಕೆ ಓದ್ಕೊಡ ಮೇಡಮ್ ಅವ್ರ ಕಡೆ ಕೊಡು, ಅಲ್ಲಿ ಮೇಡಮ್ ಅವ್ರಿಗೆ ಕೊಡಪ್ಪ. ಅವರಿಗೆ ಡಾಕ್ಟರ್ ವೀಣಾ ಕುಲಕರ್ಣಿ ಮೇಡಮ್ ಅವರು ಗೌರವವನ್ನು ನೀಡ್ತಾರೆ ಹೂಗುಚ್ಛವನ್ನು ನೀಡೋದ್ರ ಮೂಲಕ. ಹಾಂ ಎಲ್ಲರೂ ಹೋಗ್ರಿಪ್ಪ. ಮೇಡಮ್ ಓಕೆ ರೈಟ್ ಮೇಡಮ್, ಆಯಿತು ಮೇಡಮ್. ನೀವು ಈಗ ಡಾಕ್ಟರ್ ವೀಣಾ ಕುಲಕರ್ಣಿ ಮೇಡಮ್ ಅವರು ಈ ಸಭೆಯನ್ನು ಉದ್ದೇಶಿಸಿ ಮಾತನಾಡಲಿದ್ದಾರೆ.
Good afternoon, one and all present here. Sorry for keeping you waiting here in the auditorium. We are all waiting for the arrival of our beloved Kanta ma'am, and that's the reason we are trying to take as much as feedback as possible. I think let me proceed with the valedictory function, and as soon as Madam arrives, we will continue with our program also. Good afternoon, respected dignitaries on the dais and off the dais. It's time to conclude our academic extravaganza in our campus and acknowledge each and every one for their tireless efforts put in to make this event successful. And you must have heard the feedback right now about the pre-conference workshop that we conducted day before yesterday. I'm thankful to all the pre-conference workshop resource persons, and it's time to honor them. And let me do the proceedings, starting with, I request Dr. Ashwini, President, KCA, kindly accept the token of gratitude. Dr. Ashwini, Madam was the resource person of integration of AI in anatomy education. I request Dr. S.K. Deshpande sir to honor Dr. Ashwini. May I call upon Dr. Vasudha Kulkarni, ma'am? Okay. I call upon our own gynecologist, Dr. Asha Nervi, ma'am. Ma'am conducted surgical anatomy of pelvis workshop, one of the resource person. Ma'am, kindly come over onto the stage and accept our token of gratitude. May I now call upon Dr. Suresh Badigate sir, HOD, Department of Surgery in our own institution. And sir really threw light in the workshop surgical anatomy of pelvis along with Dr. Asha Nervi ma'am. Sir, kindly come on to the dais to accept the honor. I request Dr. Shilpa Bhimalli to come on to the dais. Madam is professor in JNMC Belgium and has been resource person of problem-based learning workshop along with Dr. Vijaya ma'am. And as you just got the feedback about problem-based learning, kindly give a big round of applause to Dr. Shilpa Bhimalli ma'am. Dr. Rekha Hiremat, kindly join. And Dr. Manjula Patil, kindly come on to the dais. May I call upon Dr. Komala, please kindly accept the token of gratitude. Ma'am has been resource person for AI in anatomy education along with Dr. Ashwini, Dr. Seema. Kindly come over onto the dais, ma'am. Now it's time to felicitate our own KCA office bearers and executive committee members who have traveled from different districts of Karnataka and has been part of this event, without whom this event wouldn't have been successful. A big round of applause to all of them. And as Dr. Vinay and Dr. Roshni call out the names, I would like to felicitate each one of them.
First, Dr. N.M. Suresh, Vice President, KCA. Sorry. Dr. Vidya C.S., Vice President, KCA. Dr. Meenakshi Parthasarthi, Editor-in-Chief, Karnataka Chapter of Anatomists Journal. Next, Dr. Padmalata K, Executive Committee Member, KCA. Dr. Akhilandeshwari K, Executive Member, KCA. Dr. Parshram Rajapur Sir. Dr. Asha KR. Dr. Asha KR. Dr. Rohini Punja. Dr. Jyoti Casey. Dr. Vinuta SP. Dr. Vijay Kumar S. Dr. Shashank MJ. Thank you. We would also like to felicitate our KMC observer, Dr. Nagaraj Bhatt, who has been patiently watching and taking note of all the activities that's happening throughout the conference. And Sir has given extreme good feedback about our conference. Thank you, sir, for gracing the occasion and being here, being with us. Thank you.
So you would have realized that to keep you all in good spirit, we conducted even sports event, and few of the delegates interestedly participated in this event, in some of the events. And may I call upon Dr. Nagraj Mallashetty, professor of our department, to announce the prize winners of the sports event.
The winners of the shuttle badminton men, Dr. J. Santosh Kumaran, ASI Medical College and Hospital, Gulbarga.
Kindly give a big round of applause. In spite of the busy schedule academic sessions, sir had the zeal to play, take part in the sports. Yeah, thank you. Please come and congratulations.
Runner-up, Dr. Hariharan S. from Mandya Institute of Medical Science, Mandya.
ಮತ್ತು ನಿಮ್ದು ಏನಾರ ಇದ್ರೆ ಹೇಳ್ರಿ. ಸೊ ನಮ್ಮ ಈ ಕರ್ನಾಟಕ ಅಂಗರಚನಾ ಶಾಸ್ತ್ರ ಒಕ್ಕೂಟದ 25ನೇ ವರ್ಷದ ಈ ಸಂಭ್ರಮಾಚರಣೆ ಅತ್ಯದ್ಭುತ ರೀತಿಯಲ್ಲಿ ಅತ್ಯಂತ ಒಂದು ನಾವು ಏನು ಸುವರ್ಣಾಕ್ಷರಗಳಲ್ಲಿ ಬರೆದಿಡುವಂತಹ ಒಂದು ಇತಿಹಾಸವನ್ನು ನಿರ್ಮಿಸ್ತು ಅಂತ ಹೇಳೋಕ್ಕೆ ಬಹಳ ಹರ್ಷವೆನಿಸ್ತಾ ಇದೆ. ಈ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ನಮಗೆ ಒಂದು ಅಮೋಘವಾದಂಥ ನೆರವು ನೀಡಿದವರಪ್ಪ ಅಂತಂದರೆ SDM ಸಂಸ್ಥೆಯವರು. ಈ ಒಂದು 25ನೇ ವರ್ಷದ ಬೆಳ್ಳಿ ಹಬ್ಬವನ್ನು ನಾವು ಎಲ್ಲಿ ಮಾಡಬೇಕು ಅಂತ ವಿಚಾರ ಮಾಡ್ತಾ ಇದ್ದಾಗ ಡಾಕ್ಟರ್ ವೀಣಾ ಕುಲಕರ್ಣಿ ಮೇಡಮ್ ಅವ್ರು ಬಂದು ನಾವು SDML ಮಾಡ್ತೀವಿ ಸರ್ ಅಂಥೇಳಿ ರಿಕ್ವೆಸ್ಟ್ ಮಾಡಿದರು. ಕಾಂತಾ ಮೇಡಮ್ ಅವರು ಒಪ್ಕೊಂಡ್ರು. ಆ ಪ್ರಕಾರ ಏನು ನ ಭೂತೋ ನ ಭವಿಷ್ಯತಿ ಅನ್ನುವ ರೀತಿಯಲ್ಲಿ ಈ ಒಂದು ಕಾನ್ಫರೆನ್ಸನ್ನು ಅವರು ನಡೆಸಿಕೊಟ್ರು ಅಂತ ಹೇಳೋಕ್ಕೆ ಬಹಳ ಸಂತಸ ಅನ್ನಿಸ್ತಾ ಇದೆ. ಯಾಕಂದರೆ ಒಂದು ಕಾನ್ಫರೆನ್ಸ್ ಆಗ್ಬೇಕಂತಂದರೆ ಬಹಳಷ್ಟು ಅಲ್ಲಿ ಕಾರಣಗಳನ್ನು ನಾವು ಹುಡುಕ್ಬೇಕಾಗತ್ತೆ. ಒಂದು ಏನಪ್ಪ ಅಂದ್ರೆ ಸೈಂಟಿಫಿಕ್ ಸೆಷನ್ ಫಸ್ಟ್, ಮತ್ತು ಏನಪ್ಪ ಅಂತಂದರೆ ಗೆಸ್ಟ್ ಟಾಕ್ಸ್ ಮತ್ತು ವರ್ಕ್ಶಾಪ್ಸ್, ಮತ್ತು ಅದು ಎಲ್ಲದರ ಜೊತೆ ಒಳ್ಳೆಯ ಊಟ ಕೊಡಬೇಕು, ಒಳ್ಳೆಯ ಆತಿಥ್ಯ ಕೊಡಬೇಕು. ಎಲ್ಲದಕ್ಕಿಂತ ಹೆಚ್ಚಿಗೆ ಸೆಕೆಂಡ್ ಡೇ ಈವ್ನಿಂಗ್ ಒಳ್ಳೆ ಬ್ಯಾಂಕ್ವೆಟ್ ಇರಬೇಕು, ಅದ್ರ ಜೊತೆ ಒಳ್ಳೆಯ ಸಂಗೀತ ಇರಬೇಕು, ಒಳ್ಳೆ ಡ್ಯಾನ್ಸ್ ಇರಬೇಕು. ಹೌದಾ? ಇವೆಲ್ಲವುಗಳು ಸೇರಿದರೆ ಒಂದು ಸಮಾರಂಭ ಅಥವಾ ಕಾನ್ಫರೆನ್ಸ್, ಒಂದು ಸಮ್ಮೇಳನ, ಯಶಸ್ವಿ ಸಮ್ಮೇಳನ ಅಂತ ಹೇಳ್ತೀವಿ. ಅಂಥ ಎಲ್ಲದರಲ್ಲೂ ಅವರು ಒಂದು ವರ್ಕ್ಶಾಪ್, ಫಸ್ಟ್ ಡೇ ವರ್ಕ್ಶಾಪ್ನಲ್ಲಿ ಅಭೂತಪೂರ್ವವಾದಂತಹ ಒಂದು ವರ್ಕ್ಶಾಪನ್ನು ಅತಿರಥ ಮಹಾರಥರು ಡಾಕ್ಟರ್ ಅಶ್ವಿನಿ ಮೇಡಮ್, ವಸುಧಾ ಮೇಡಮ್ ಅಂತ ಅತಿರಥ ಮಹಾರಥರು ಆ ಕಾರ್ಯಕ್ರಮಗಳನ್ನು ನಡೆಸಿಕೊಟ್ರು. ಅಂಥ ಒಂದು ಕಾರ್ಯಕ್ರಮದಿಂದ ಆರಂಭಗೊಂಡಂಥ ಈ ಸಮ್ಮೇಳನ 2ನೇ ದಿನ ಬಹಳಷ್ಟು ಅದ್ಭುತವಾದ ಲೆಕ್ಚರರ್ಸ್ ಇದ್ದು, ಅದರಾಗ ಅದ್ರ ಜೊತೆನೇ ಮತ್ತು ಸೈಂಟಿಫಿಕ್ ಸೆಷನ್ ಒಂದು ರಸದೌತಣವನ್ನು ನೀಡ್ತು. ಎಲ್ಲ ಅದ್ಭುತವಾದಂಥ ರಸದೌತಣವನ್ನು ನೀಡಿದರು. ಮೇಡಮ್ ಈಗ ಅಶ್ವಿನಿ ಮೇಡಮ್ ಎಲ್ಲವನ್ನ ಅದ್ರ ಜೊತೆ ಇನ್ನೊಂದು ಎಕ್ಸ್ಟ್ರಾ ಇಟ್ಟಿದ್ರು ಇವರು SDM ದವರು, ಸ್ಪೋರ್ಟ್ಸ್. ಸೊ ಇವೆಲ್ಲವುಗಳನ್ನು ಸೇರಿ ಊಟ, ಆತಿಥ್ಯ, ಸಂಗೀತ, ಸೈಂಟಿಫಿಕ್ ಎಲ್ಲವನ್ನ ಸೇರಿ ಈ ಒಂದು ಸಮ್ಮೇಳನ ಅತ್ಯಂತ ಯಶಸ್ವಿ ಸಮ್ಮೇಳನಗಳಲ್ಲಿ ಒಂದು ಹೆಸರನ್ನು ನೀಡಿತು. ಈ ಸಂಘಟನೆಯನ್ನು ನಡೆಸಿಕೊಟ್ಟಂಥ ಎಲ್ಲರೂ ಪರಮ ಪೂಜ್ಯ ಸನ್ಮಾನ್ಯ ವೀರೇಂದ್ರ ಹೆಗ್ಡೆ ಅವರು, ಡಾಕ್ಟರ್ ಕಾಂತಾ ಮೇಡಮ್ ಅವರು ವೇದಿಕೆಗೆ ಆಗಮಿಸ್ತಾ ಇದ್ದಾರೆ. ದಯವಿಟ್ಟು ಎಲ್ಲರೂ ಎದ್ದು ನಿಂತು ಮೇಡಮನ್ನು ಸ್ವಾಗತ ಮಾಡಬೇಕು. ಡಾಕ್ಟರ್ ಕಾಂತಾ ಮೇಡಮ್ ಅವರು ವೇದಿಕೆಗೆ ಬರ್ತಾ ಇದ್ದಾರೆ. ದಯವಿಟ್ಟು ಎಲ್ಲರೂ ಮೇಡಮ್ ಅವ್ರಿಗೆ ಗೌರವ ಸಲ್ಲಿಸ್ತಾ ಇದ್ದಾರೆ. ಥ್ಯಾಂಕ್ ಯು. ಈಗ ನೂತನ ಈ ಒಂದು ಸಮ್ಮೇಳನದ ಯಶಸ್ಸಿನೊಂದಿಗೆ ಅತ್ಯಂತ ಹರ್ಷದಲ್ಲಿ ತೇಲುತ್ತಿರುವ ಡಾಕ್ಟರ್ ವೀಣಾ ಕುಲಕರ್ಣಿ ಮೇಡಮ್ ಅವರು ಈ ಸಭೆಯನ್ನು ಉದ್ದೇಶಿಸಿ ಮಾತನಾಡಬೇಕು ಅಂತ ಅವ್ರನ್ನ ಕೇಳ್ಕೊಳ್ತಾ ಇದ್ದೀನಿ.
Good afternoon, respected Kanta ma'am. We are extremely glad to have you with us for the valedictory function. It's time to wind up and thank the team behind this conference, backbone behind this conference, our own organizing committee members for having put up such a great show, and they have worked tirelessly and put in all the efforts to bring light and color to this conference. It's my privilege to honor and felicitate Dr. Suresh Mangutti, Joint Organizing Secretary and Treasurer, whose meticulous calculations, efforts have really brought a significant upliftment to this conference. Sir has also been, he is also treasurer of this conference along with being joint organizing secretary. And I request Dr. Kanta ma'am to present a token of gratitude to Dr. Suresh Mangutti. A big round of applause for all the efforts taken by Dr. Suresh Mangutti. May I call upon our chief advisors, Dr. A.V. Kulkarni sir and Dr. S.K. Deshpande sir, to accept the token of gratitude from Dr. Kanta ma'am. Dr. A.V. Kulkarni sir, Dr. S.K. Deshpande sir. I expect a big round of applause to our team, without whose contribution, dedication, this event would not have been possible. So as I call upon the name of each and every team member, we have to encourage them. I call upon Dr. Amar Singh sir, Dr. Nagaraj Malashetty, Scientific Committee member of our conference. Dr. Roshni Sadashiv, Assistant Professor and Scientific Committee member, has worked tirelessly to make this scientific session happen unhindered. Dr. Vinay Kulkarni, yes, and the souvenir release what you saw today, I think that the credit goes to Dr. Vinay along with our staff members, and Vinay has been taking care of transport accommodation as well. Our own Mrs. Asha Deshpande ma'am, who is in charge of stage and the smooth arrangement in the smooth execution of events on the stage. What you all are witnessing, the credit goes to Asha ma'am. I call upon Miss Immen Arupongen, yes, who is, you must have noticed a warm smile on Immen's face as you entered Kalakshetra. So reception committee in charge, Miss Immen. Accompanying Miss Immen, Dr. Mona Lisa Mondal, stage reception registration committee in charge. Yes, I'm feeling very proud to have such wonderful team by my side. It's a small team, but as you see, they have really done a wonderful job, and they have eased my burden so that I could go back and sleep well. They have tried their best to do whatever they can. Now, behind the scene, things do happen, and I would like to give credit to those who work behind the team. Let me call Mr. Pritesh, IT department, who has created wonderful website, and so that the registrations went on very smoothly. At the click of the button, you received the confirmation email, and all credit goes to Mr. Pritesh from IT department for handling the software. I request Dr. Kanta ma'am to felicitate, honor Mr. Pritesh. I request, yeah, Kanta ma'am, that's next. I call upon Mr. Devraj from Art and Photography, who has covered the events happening throughout the conference, so that we can take back the memories of the conference and treasure it lifetime. And thank you, Kanta. Social Networking Department, Mr. Devraj. And it's indeed a privilege to receive, they are receiving token of gratitude from Dr. Kanta ma'am. I request Mr. Akshay Kalakshetra in charge. Sports in charge, Mr. Sharad Javli. Mr. Mahesh, in charge of university printing and certificate. All the wonderful artwork, the flex, banners, what you are noticing is all because of the hard work of Mr. Mahesh. I thank Kanta ma'am and all the office bearers of KCA for having taken their valuable time and have traveled and have been a part of this wonderful conference. And last but not the least, I would like to thank my own family, my husband, my 2 children for bearing with me all these months, I can say. And they are right here in the audience. My 2 daughters are sitting there. Vaishnavi and Vibha.
We want Vijay sir also.
Vaishnavi is our own student. She just completed her second year MBBS exam yesterday, and she presented the paper. And that's Vibha. And thank you so much. Yeah, and so it's time to say goodbye and take. Yes, yeah, and now the most awaiting part of the, yes, so the most awaiting part of this event, the prize distribution for scientific sessions, and all the, I can see eager, enthusiastic faces waiting here to receive the token of appreciation from Dr. Kanta ma'am. I request Dr. Nagraj to announce the best paper awardees.
I'm very happy to announce that in this conference we had total 192 presentations, faculty oral 94, and faculty poster presentations were 26, and undergraduate presentations oral 62 and poster 10. First, I will announce the Best Paper Awards conducted on date 23 August. So, Best Paper in Oral Presentations under Faculty category, conducted in Hall 1, Session 1st. It goes to Dr. Deepa G, AIMS, BB Nagar. Okay. Session 2, Hyderabad, sir. Andhra Pradesh, Telangana, sorry. Yes. The best paper in session 2 goes to Dr. Viveka S., Sridevi Institute of Medical Science, Hospital, Tumkuru. Okay. Hall 2, session 1. The best paper goes to Dr. Vidya R., Akash Institute of Medical Science and Research Center, Bengaluru. Not coming. She left, madam. Session 2. It goes to Dr. Sandhya Vikas Yadgiri, BLD Institute of Medical Science, S3 BM Patil Medical College, Vijayapura. Best paper in session 1, Hall 3 goes to Dr. Veena Vidyashankar, MS Ramaya Medical College, Bengaluru. Best paper in session 2, Hall 3 goes to Dr. Suma MP, BGS Medical College, Nagaruru. I think so. Now, the best paper in session 1 of Hall 4 goes to Dr. Mahantesh Ramannavar, KLE Sri VMK Ayurvedic Medical College, Belagavi. Best paper in session 2, Hall 4 goes to Dr. Rachana Raghavendra Kulkarni. Now presentations conducted in hall number 5. It is for students. Session 1, Hall 5. The best paper goes to Miss Junita Babu, Ramaya Medical College, Bengaluru. Anyone can take from that college if she has. Best paper in session 2, Hall 5 goes to Miss Diksha Kavali, SDM Medical College and Hospital, Dharwada. Now, best paper in presentation in the poster presentation category for faculty. Session 1, the best poster is Dr. Jyoti KC, Ramaya Medical College, Bengaluru. Best paper in session 2, best poster in session 2, Dr. Padmalata, ESIC Medical College, Chennai. Poster to Padmalata. Students categories. Yes, ma'am. Now, for undergraduates, the best paper in session 1, Hall 1, Mr. Ashutosh Porwal, JNMC, Belagavi. Okay. In Hall 2, Miss Saurabhya Srinivasan, Raja Rajeshwari Medical College, Bengaluru. Hall 3, Miss Atmika A, Raja Rajeshwari Medical College. Hall 4, Mr. Jaichada, ESIC Medical College. Hall 5, Miss Arya K. Sridhar, ESIC Medical College, Bengaluru. Best poster, Mr. Tarun Andhra, Akash Institute of Medical Science, Bengaluru. Thank you.
Right. Now, even though our teaching staff, we are a small department, tiny department, but we have a wonderful, enthusiastic, proactive, non-teaching staff team, and their efforts are astonishing, and they have really put in lot of efforts. I request all our non-teaching staff members just to come on to the dais, and we all would want to cheer you. Give a big round of applause. Mr. Singarao, you just come, be on the dais. Mr. Vittal, Mr. Darshan, Maktum, Mr. Baswaraj, Mr. Mahavir. Yeah, yes, and ma'am, yes. Just a minute, ma'am, we are getting. Kindly accept the token of gratitude from Kanta ma'am for all your efforts. Any job, any task is instructed, immediately it is done. I should give the credit to the entire team. They followed all the instructions very sincerely, and we are really proud to have such wonderful non-teaching staff with us. Mr. Shashidhar. Yeah, now it's time to acknowledge the efforts of our wonderful, enthusiastic, young volunteer committee, undergraduate students. Yeah, a big round of applause to the whole team. I call upon all our volunteers, girls, boys, kindly come on to the dais. Yeah, come. Yes, yes. Ma'am, this is our student volunteers. Take blessings from Kanta ma'am and just proceed ahead. Yeah, we will. would like to call Mr. Spandan. Mr. Spandan. Other staff volunteers, Sudha, Swapna, yeah, they are not here in the call. Rameshri.
ಈ
Mr. Spandan from microbiology department. Kindly accept the token of gratitude. Miss Chetna from biochemistry department. Miss Ramya Shri from biochemistry department. Okay. Miss Josna from the Department of Anatomy, new joint staff, just one day before. Two more staffs were there. One is Dr. Swapna and one is Miss Sudha from the physiology department. Thank you.
ಅದೇ ಕರಿತೀನಿ ಒಂದು ನಮ್ಮ ಜನ ಬಿಟ್ಟರೆ ನಿಮ್ಮ ಜನ ಎಲ್ಲ ಆಯ್ತಾ? ಈ ಕಾರ್ಯಕ್ರಮದ ಯಶಸ್ವಿಗೆ ಡಾಕ್ಟರ್ ಕಾಂತಾ ಮೇಡಮ್ ಅವರು ಬಂದಿರೋದು ಬಹಳ ದೊಡ್ಡ ಪ್ರೇರಣೆ. ಅವರು ಒಂದು ದಿನ ಮೊದಲೇ ಬಂದರು. ಮತ್ತು ಕಾರ್ಯಕ್ರಮ ಎಲ್ಲದಕ್ಕಿಂತ ಬೆಸ್ಟ್ ಪಾರ್ಟ್ ಏನಪ್ಪ ಅಂತಂದರೆ ರಾತ್ರಿ ನಿನ್ನೆ ಬ್ಯಾಂಕ್ವೆಟ್ ಮುಗಿಯುವವರೆಗೆ ಕೂತು ಮತ್ತು ಕೊನೆಗೆ ತಮಗೆ ಇಷ್ಟವಾದಂಥ ಹಾಡನ್ನು ಹೇಳಿಸಿ ಅವರು ಖುಷಿಪಟ್ಟರು. ಅವ್ರಿಗೆ ನಿಮ್ಮನ್ನು ಹೊಗಳ್ತಾ ಇಲ್ಲ ಮೇಡಮ್. ಪ್ರತಿ ಟೈಮ್ ನಮಗೆ ದಿಗ್ವಿಜಯ ಮೇಡಮ್ ಅವ್ರ ಜೊತೆ ಕಂಪ್ನಿ ಕೊಡ್ತಿದ್ದ. ಬಟ್ ನಮಗದೊಂದು ದೊಡ್ಡ ಸಮಸ್ಯೆ ಆಗಿತ್ತು. ದಿಗ್ವಿಜಯ ಇಲ್ಲ ಅಂದರೆ ಮೇಡಮ್ ಅವ್ರನ್ನ ಹೆಂಗೆ ಅಂತ. ಬಟ್ ಮೇಡಮ್ ಅವ್ರನ್ನ ಡಾಕ್ಟರ್ ಉಮಾ ಹಿರೇಮಠ್ ಮೇಡಮ್ ಅವರು ದಯವಿಟ್ಟು ಬಂದು ವೇದಿಕೆ ನಮ್ಮೆಲ್ಲರ ಕೃತಜ್ಞತೆಗಳನ್ನು ಗೌರವಪೂರ್ವಕವಾಗಿ ಅವರಿಗೆ ಸಮರ್ಪಿಸ್ತಾ ಇದ್ದೀವಿ. ಡಾಕ್ಟರ್ ಉಮಾ ಹಿರೇಮಠ್ ಮೇಡಮ್ ಅವರು 4 ದಿನಗಳ ಕಾಲ ಮೇಡಮ್ ಅವ್ರ ಜೊತೆ ಇದ್ದು 4 ದಿನ ಅವ್ರಿಗೆ ನಮ್ಮೆಲ್ಲರ ಪರವಾಗಿ ಕೃತಜ್ಞತೆಯನ್ನು ಸಮರ್ಪಣೆ ಮಾಡ್ಬೇಕು. ಮೇಡಮ್ ಹೋಗ್ರಿ. ಡಾಕ್ಟರ್ ಉಮಾ ಹಿರೇಮಠ್ ಮೇಡಮ್ ಅವರು ಅಲ್ಲಿದೆ ಅವರು 4 ದಿನಗಳ ಕಾಲ ಮೇಡಮ್ ಅವ್ರ ಜೊತೆ ಇದ್ದು ಅವರ ಎಲ್ಲ ಒಂದು ಕೆಲಸವನ್ನು ನೋಡಿಕೊಂಡಿದ್ದಾರೆ. ಅವರಿಗೆ ನಮ್ಮೆಲ್ಲರ ಪರವಾಗಿ ಎಲ್ಲದಕ್ಕಿಂತ ಹೆಚ್ಚಾಗಿ ನಮ್ಮ ಮೇಡಮ್ ಅವರ ಫೇವರೇಟ್ ಸ್ಟೂಡೆಂಟ್ ಅವರು. ನಾನು ಹೌದ್ರಿ ಮೇಡಮ್. ಎಸ್, 4 ದಿನಗಳ ಕಾಲ ಮೇಡಮ್ ಅವ್ರನ್ನ ಎಲ್ಲ ರೀತಿಯಾದಂಥ ಅವ್ರಿಗೆ ಅನುಭವಗಳನ್ನು ನೋಡಿಕೊಂಡಂಥ ಡಾಕ್ಟರ್ ಉಮಾ ಹಿರೇಮಠ ಅವ್ರಿಗೆ ಅನಂತ ಧನ್ಯವಾದಗಳು. ಇನ್ನೂ ಒಬ್ಬರು ನಾವು ನೆನೆಸಲೇಬೇಕು. ನಮ್ಮ KCA ಸ್ಪೆಷಲ್ ಆಫೀಸರ್ ಅಂತ ಅವ್ರಿಗೆ ಅಪಾಯಿಂಟ್ ಮಾಡಿದ್ದೀವಿ. ಡಾಕ್ಟರ್ ಪರಶುರಾಮ್, ಪ್ರೊಫೆಸರ್ ಆಫ್ ಎನಾಟಮಿ, ಮೈಸೂರು ಮೆಡಿಕಲ್ ಕಾಲೇಜ್. ಸಚ್ಚೆ ಒಳ್ಳೆ ಅತಿ ತಮ್ಮ ಒಳ್ಳೆಯತನದಿಂದ ಎಲ್ಲರ ಪ್ರೀತಿಯನ್ನು ಗೆದ್ದು, ವಿಶೇಷವಾಗಿ ಡಾಕ್ಟರ್ ಕಾಂತಾ ಮೇಡಮ್ ಅವರ ಎಲ್ಲ 4 ದಿನಗಳ ಕಾಲ ಪ್ರತಿ ನಿಮಿಷವೂ ಮೇಡಮ್ ಅವರ ಸೇವೆಯನ್ನು ಮಾಡಿದ್ವಿ. ಒಂದು ನಮಗೆಲ್ಲ ರೀತಿಯ ಸಹಾಯ ಮಾಡಿದ ಡಾಕ್ಟರ್ ಪರಶುರಾಮ್, ಡೌನ್ ಟು ಅರ್ತ್ ಪರ್ಸನ್, ಅವರಿಗೆ ನಮ್ಮೆಲ್ಲರ ಪರವಾಗಿ ಅನಂತ ಧನ್ಯವಾದಗಳನ್ನು ಅರ್ಪಣೆ ಮಾಡ್ತಿದ್ದೀವಿ. ಡಾಕ್ಟರ್ ಪರಶುರಾಮ್ ಮೇಡಮ್ ಅವರು MMC ಒಳಗೆ ಪ್ರಿನ್ಸಿಪಲ್ ಆಗಿ DMA ಆಗಿ ಹಂಗೆ ಮೇಡಮ್ ಅವರ ಆಶೀರ್ವಾದದಿಂದ ತಾವು ಉನ್ನತವಾದ ಸ್ಥಾನಗಳನ್ನು ತಲುಪಲಿ ಅಂತ ಹಾರೈಸ್ತಾ, ಸೊ ಈಗ ಈ ಕಾರ್ಯಕ್ರಮವನ್ನು ಉದ್ದೇಶಿಸಿ ಈ ಸಭೆಯ ಅಧ್ಯಕ್ಷತೆಯನ್ನು ವಹಿಸಿದಂಥ ಡಾಕ್ಟರ್ ಅಶ್ವಿನಿ ಮೇಡಮ್ ಅವರು ಮಾತಾಡಬೇಕು.
Good afternoon to everyone. I will not take too much time. First of all, I would like to thank the organizing team under the leadership of Dr. Veena Kulkarni for giving us an academic feast and 2 days full of, there was education, there was learning, there was networking happening in the past 3 days, and we had a nice, the banquet. We enjoyed all the hospitality. So I wholeheartedly on behalf of Karnataka chapter of Anatomists, thank you and your team. Without a team, nothing happens, and I think they've all joined hands to give a good show. Thank you, Dr. Veena, and all the staff of Department of Anatomy, SDM University, and the management who supported you for this. Now we would like Kanta ma'am to kindly felicitate Dr. Veena Kulkarni, and as well as in absentia Dr. Vijay Kulkarni, the principal of SDM. Thank you, ma'am. And for the Silver Jubilee celebrations which we conducted on August 22, each of the KCA office bearers have done a splendid job. The problem was we were not together in the same place or the same venue. We had to communicate through Zoom meetings, do the purchases and everything, and organize the program. So on behalf of KCA again, I would thank each and every office bearer of the Karnataka chapter of Anatomists for bringing out this Silver Jubilee function into a great success. Thank you all. Now, today my presidentship ends, and I need to hand over the President's Medal to Dr. Veena Kulkarni, who will be the new president for the next year, which is from now till the next conference. Congratulations, Dr. Veena.
ನಾವು ಫೆಲಿಸ್ಟೇಷನ್ ಒಂದೇ ನಿಮಿಷ ಮೇಡಮ್. ಈ 25ನೇ ಬೆಳ್ಳಿ ಹಬ್ಬದ ನಿಮಗೆ ನೀವು ಮಾತಾಡಂತೆ ಕಾಂತಾ ಮೇಡಮ್ ಅವರು ಮಾತನಾಡಬೇಕು.
ಹಲೋ, ನನ್ನ ನೆಚ್ಚಿನ ಬಂಧುಗಳೇ, ಈ ಕನ್ನಡದಲ್ಲಿ ತಪ್ಪಾಗಿದೆ ಕ್ಷಮಿಸಬೇಕು. ಯಾವಾಗಲೂ ಭೂಸಾರೆಡ್ಡಿಯವರು ತಾನೇ ಕನ್ನಡ ಪಂಡಿತನೆಂದು ಕನ್ನಡದಲ್ಲೇ ಮಾತಾಡ್ತಿದ್ರು. ಇವತ್ತು ನಾನು ಚಾಲೆಂಜ್ ಆಗಿ ಸ್ವಲ್ಪ ಕನ್ನಡದಲ್ಲಿ ಮಾತಾಡೋಣ ಅಂತ ಮಾತಾಡ್ತಾ ಇದ್ದೀನಿ. ಎಲ್ಲ ಬಚ್ಚಿಟ್ಕೊಂಡ್ರಲ್ಲ ಅವರು. ಈ ಕನ್ನಡ ಪಂಡಿತರು ಏನಂದರೆ ಇಂಗ್ಲೀಷ್ ಬರೋಲ್ಲ, ಅದಕ್ಕೋಸ್ಕರ ಕನ್ನಡದಲ್ಲಿ ಹೊಡಿತಾ ಇದ್ದಾರೆ. ಇದೇ ನಮ್ಮೆಲ್ಲರ ಗುಟ್ಟು. ಈ ದಿನ ನಾನೇನೋ ಸ್ವಲ್ಪ ನೆನೆ ಕೋಪವಾಗಿದ್ದೆ. ಅದು ಸದೇ ಸಾಧಾರಣ. ತಾಯಿ ಯಾವಾಗಲೂ ಬೇರೆಯವರ ಹಿತವಚನ, ಮಕ್ಕಳ ಹಿತವಚನ ನೋಡೋದೇ ಅವಳ ಭಾಗ್ಯ. ಎಲ್ಲಾದರೂ ಸ್ವಲ್ಪ ಕುಂದುಕೊರತೆ ಆದರೆ ಅವಳ ಮನಸ್ಸು ಎಷ್ಟು ನೋವುತ್ತೆ ಅನ್ನೋದು ಎತ್ತಿ ಹೇಳ್ತಾಳೆ. ಕಣ್ಣಲ್ಲಿ ನೀರು ಬಿಡ್ಬೋದು. ಆದರೆ ನಾನು ಸ್ವಲ್ಪ ಕೋಪದಿಂದ ಮಾತಾಡಿದೆ, ಅಷ್ಟೇ ಡಿಫ್ರೆನ್ಸು. ಹೋಪ್ ನೀವೆಲ್ಲ ನನ್ನ ಕ್ಷಮಿಸ್ತೀರಿ ಅಂತ ತಿಳ್ಕೊಂಡಿದ್ದೀನಿ. ಅದು ಯಾವ ವಿಧವಾದ ದ್ವೇಷದಿಂದಲ್ಲ, ಅದು ಒಂದು ವಿಧವಾದ ಸಂಪೂರ್ಣ ಪೂರ್ತಿಯಿಂದ ನಿಮ್ಮನ್ನೆಲ್ಲೂ ಚೂರು ಬೈದೆ. ಮತ್ತು ಅದಕ್ಕೆ ಫಂಕ್ಷನ್ಗೂ ಬಂದು ಬ್ಯಾಂಕ್ ಹೋಟೆಲ್ ಕೂತು ಕೊನೆವರೆಗೂ ಹಾಡುಗಳನ್ನ ಕೇಳಿಸ್ಕೊಂಡು ಸಂತೋಷವಾಗಿ ಆ ಭೂಸಾರೆಡ್ಡಿ ನನ್ನ ಹೊರಗಡೆ ಹಾಕೋವರೆಗೂ ಅಲ್ಲೇ ಇದ್ದು ನಂತರ ಹೊರಗಡೆ ಬಂದೆ. ಈಗ ವಿಷಯಕ್ಕೆ ಬರೋಣ. ಏನಂದರೆ, ಸತತವಾಗಿ ಈ KCAನಲ್ಲಿ ದುಡಿದಂಥ ವ್ಯಕ್ತಿಗಳು ಕೆಲವರೇ, ತಪ್ಪು ತಿಳ್ಕೊಬೇಡಿ, ಎಲ್ಲರೂ ಇದ್ದೀರಿ. ಕೆಲಸ ಮಾಡೋರು ಕೆಲವ್ರಿಗಿರುತ್ತೆ, ಅಭಿರುಚಿ ಇರಬೇಕು, ಅದರಲ್ಲಿ ಶ್ರದ್ಧಾ ಭಕ್ತಿಗಳಿರಬೇಕು, ಮತ್ತು ಇದು ನನ್ನ ಸಂಸ್ಥೆ, ನಾನು ದುಡಿಬೇಕು ಅನ್ನೋ ಆಸೆ ಇರಬೇಕು. ಇವು ಯಾವುದೂ ಇಲ್ಲ ಅಂತಂದರೆ ಸರ್ವೇ ಸಾಧಾರಣ ಬರ್ತೀವಿ, ಕಾನ್ಫರೆನ್ಸ್ ಅಟೆಂಡ್ ಮಾಡ್ತೀವಿ, ಅರ್ಧ ಹೊರಗಡೆ ಪಿಕ್ನಿಕ್ ಸ್ಪಾಟ್ಗೆ ಹೋಗ್ತೀವಿ ಮತ್ತು ಬರ್ತೀವಿ. ಇದು ಒಂಥರ ವಿಧವಾದ ನಮ್ಮ ಅನಾಟಮಿಸ್ಟ್ಗಳ ಕತೆ. ಇಲ್ಲಿ ನಾನು ಸರ್ವೇ ಸಾಧಾರಣವಾಗಿ ನೋಡ್ತಾ ಬಂದರೆ ರಾತ್ರಿ 10 ಗಂಟೆ ಆದ್ರೇನು ನನ್ನ ಮನೆ ಬಾಗಿಲು ತಟ್ಟೋರು. ಯಾರಪ್ಪ 10 ಗಂಟೆ 10:30 ಬಾಗಿಲು ತಟ್ಟೋದು ಅಂದರೆ 2 ಗಿಣಿಗಳು, ಅದು ಹೆಣ್ಣು ಗಿಣಿಗಳು. ಒಂದು ಅಶ್ವಿನಿ, ಇನ್ನೊಂದು ಮೀನಾಕ್ಷಿ, 2 ಬಂದು ನಿಂತಿರೋ. ರಾತ್ರಿ 10:30 ಬಂದರೆ ನಾನು ಕಣ್ಣು ಉಚ್ಕೊಂಡು ಬರೋದು. ಬಂದರೆ ಇವರಿಬ್ಬರು, ನನ್ನ ಮಗ ಸಂತೋಷ್ ಕುಮಾರ್ ಹೇಳ್ತಾಯಿದ್ದ, ಅಮ್ಮ ಬಂದರು ಇಬ್ಬರು ಅಂತ. ಎಲ್ರಿಗೂ ಗೊತ್ತು ಇವರೇ ಬರೋದು ಅಂತ. ಬಂದರು 11:12 ಗಂಟೆ ಆದ್ರೂ ಹೋಗೋಲ್ಲ, ಹೊಟ್ಟೆ ಇಲ್ಲ, ನಿದ್ರೆ ಇಲ್ಲ, ಏನೂ ಇಲ್ಲ. ಆ ಥರ ಕಷ್ಟ ದುಡಿದಂಥ ವ್ಯಕ್ತಿಗಳು ಅಂದರೆ ಬಹಳ ವಿರಳ. ಅವ್ರ ಜೊತೆಲಿ ಇನ್ನೊಂದು ಲಿಲಿಪುಟ್ ಸೇರಿಕೊಳ್ತು. ಅದು ಯಾವುದು ಅಂದರೆ ಈ ವೀಣಾ. ಇವಳು ಸಾಲದಕ್ಕೆ ಯಾವಾಗ ಒಂದು ಫೋನು, ಮೇಡಮ್ ಇದು ಸರಿನಾ, ಮೆನು ಅದಾಕ್ಲ. ನಾನು ಹೇಳಿದೆ ಮೆನು ಕಳಿಸ್ಕೊಡ್ಬಿಡು ವಾಟ್ಸಪ್ಪಲ್ಲಿ, ನೋಡ್ತೀನಿ ಅಂತ. ಅಲ್ಲಿಂದನೇ ನೋಡಿದ್ರೆ ಒಳ್ಳೆ ಇಂಟರ್ನ್ಯಾಷನಲ್ ಕಾನ್ಫರೆನ್ಸ್ ಮಾಡೋ ಥರ ಮಾಡಿದ್ದೀಯಲ್ಲಪ್ಪ ನಿನ್ನ ಮೆನು, ನನಗೆ ಅದಕ್ಕೆ ಸೆಲೆಕ್ಟ್ ಮಾಡೋ ಚೈತನ್ಯ ನನಗಿಲ್ಲ ತಾಯಿ ಅಂತ ಕಳಿಸ್ದೆ. ಈ ರೀತಿ ಈ ಮಕ್ಕಳು ನಾನಾ ವಿಧವಾಗಿ ತಮ್ಮ ಶ್ರದ್ಧೆ ಭಕ್ತಿ ಅತಿ ವಿನಯಪೂರ್ವಕವಾಗಿ ಸೇವೆ ಸಲ್ಲಿಸೋದ್ರಿಂದ ನೀವೆಲ್ಲರೂ ಎದ್ದು ನಿಂತು ಅವರಿಗೆ ಚಪ್ಪಾಳೆ ತಟ್ಟಬೇಕಾಗಿ ಕೇಳ್ಕೊತೀವಿ. ಥ್ಯಾಂಕ್ ಯು. ಕಷ್ಟ ಕಾಲದಲ್ಲಿ ಒಂದು ಹೆಣ್ಣು ಮಗಳು ಯಾವಾಗಲೂ ಎದ್ದು ನಿಲ್ತಾಳಂತೆ. ಇದು ಎಲ್ರಿಗೂ ಗೊತ್ತಿರೋದೆ. ಒಂದು ಹೆಣ್ಣು ವಿದ್ಯಾವಂತಳಾದರೆ ಮನೆಯಲ್ಲಿರೋರೆಲ್ಲರೂ ವಿದ್ಯಾವಂತರಾಗಿ ಮಾಡಬೇಕು ಅನ್ನೋ ಆಸೆ ಇರುತ್ತೆ. ಆ ಮನೆಯ ವಾತಾವರಣವೇ ಬೇರೆ ರೀತಿ ಇರುತ್ತೆ. ಆ ರೀತಿ ನಮ್ಮ ಹೆಣ್ಣು ಮಕ್ಕಳು ಪ್ರೆಸಿಡೆಂಟ್ಗಳಾದಾಗ ಹೇಗಿರಬೇಕು ಹೇಳಿ, ಅಷ್ಟು ಕಷ್ಟಪಟ್ಟು ಕೆಲಸ ಪಟ್ಟಿದ್ದಾರೆ. ಅವ್ರು ಏನಂದರೆ ನಮ್ಮ KCA ಅನ್ನೋದು ಒಂದು ಬಹು ಎತ್ತರವಾಗಿ ಬೆಳಿಬೇಕು ಅನ್ನೋ ಆಸೆಯಲ್ಲಿ ತಮ್ಮಲ್ಲಿರೋ ದುಡ್ಡುಗಳು ಆಗಲಿ, ಟೈಮ್ ಆಗಲಿ, ಫ್ಯಾಮಿಲಿನ ಸ್ಯಾಕ್ರಿಫೈಸ್ ಮಾಡಿ ಎಲ್ಲಕ್ಕೂ ಮುಂದಾಗಿರುವಂಥ ಇಂಥ ಪವಿತ್ರವಾದ ಹೆಣ್ಣು ಮಕ್ಕಳಿಗೆ ನನ್ನ ಮನಪೂರ್ವಕವಾದ ಆಶೀರ್ವಾದ ಇದ್ದೇ ಇರುತ್ತೆ. ಇದರಿಂದ ಅಶ್ವಿನಿಗೆ, ಅವರು ಹೋಗೋರೆಲ್ಲ ಸತತವಾಗಿ ಇರೋರೆ KCAನಲ್ಲಿ, ಸುಮ್ಮನೆ ಒಂದು ವರ್ಷಕ್ಕೆ ಒಂದು ಸಲ ಹೋಗಬೇಕಲ್ಲ. ಅದರಿಂದ ಈ ಥರ ವೀಣಾಗೆ ಅದು ಕ್ಲಾಸ್ಮೇಟ್ಸ್ ಇಬ್ಬರೂ ಶೇರ್ ಮಾಡ್ಕೊಂಡಿದ್ದಾರೆ. ಮಾಡಿಕೊಂಡು ಅವ್ರು ಸ್ವಲ್ಪ ರೆಸ್ಟ್ ತೊಗೊಂಡು ಇವ್ರು ಕೊಡ್ತಿದ್ದಾರೆ. ಅವ್ರಿಗೆ ರೆಸ್ಟ್ ಅನ್ನೋದೇ ಇಲ್ಲ. ಇನ್ನೊಂದು ಕೆಲಸ ಕೊಟ್ಟಿದ್ದೀವಿ ಪರ್ಮನೆಂಟ್ ಆಫೀಸಾಗಿ ಮಾಡೋದಕ್ಕೆ. ಸೊ ಅವರು ಸದಾ KCAನೇ ಮದುವೆ ಆಗಿದ್ದಾರೆ ಅಂತ ನಾನು ಹೇಳಬಲ್ಲೆ. ಇದೇ ರೀತಿ ಮೀನಾಕ್ಷಿ ಯಾವ ಟೈಮಲ್ಲಿ ನೀವು ಕೇಳಿದ್ರೇನೋ ರೆಡಿಯಾಗಿರೋಂಥ ಮಹಾ ಮೇಧಾವಿ, ಲಕ್ಷ್ಮೀ ಪುತ್ರಿ, ಸರಸ್ವತಿ ಪುತ್ರಿ, ಎಲ್ಲದರಲ್ಲೂ ಮಿತಿಯಾಗಿ ಜನಗಳ ಸೇವೆಗೆ ಮುಂದುವರಿಯುವಂಥ ಮಹಾ ವ್ಯಕ್ತಿ. ಇಂಥ ಹೆಣ್ಣು ಮಕ್ಕಳಿರುವಂಥ KCA ಎಷ್ಟು ಪವಿತ್ರವಾದದ್ದಲ್ವ. ಗಂಡಸರು ಕೆಲಸ ಮಾಡೋಲ್ಲ ಅಂತ ತಪ್ಪು ತಿಳ್ಕೊಬೇಡಿ, ಗಂಡಸರು ಮಾಡ್ತಾರೆ, ಅದರ ಹೆಚ್ಚಾಗಿ ಮಾತಾಡೋ ಭೂಸಾರೆಡ್ಡಿ. ಸೊ ಅದರಿಂದ ಇದಕ್ಕೆ ಒಂದು ಲೀಡ್ ಮಾಡಬೇಕಲ್ಲ, ಲೀಡಿಂಗ್ ದ ಲೈಟ್ ಅಂತ, ಕಿಂಡಲ್ ದ ಲೈಟ್ ಅಂತ, ಮಾರ್ಚ್ ಫಾಸ್ಟ್ ಅಂತ, ಇನಿಷಿಯೇಷನ್ ಅಂತ ಏನಾದರೂ ಹೇಳ್ಕೊಳ್ಳಿ, ಅದಕ್ಕೆ ಒಂದು ಶಕ್ತಿ ಇರಬೇಕು. ಯೂಶಲಿ ನಮ್ಮ ತತ್ವದಲ್ಲಿ ಏನು ಹೇಳುತ್ತೆ, ಶಕ್ತಿನೇ ಮುಖ್ಯ ಅಂತಾರೆ. ತಪ್ಪು ತಿಳ್ಕೊಬೇಡಿ, ನಾನು ಆ ಕಡೆ ಈ ಕಡೆ ಮಾತಾಡ್ತೀನಿ ಅಂತ. ನನಗೆ ಗಂಡು ಒಂದೇ ಹೆಣ್ಣು ಒಂದೇ. ಆದರೆ ಇವರಲ್ಲಿ ಅತಿಯಾದ ಶಕ್ತಿ ಇರುತ್ತೆ. ಹೆಣ್ಣು ಮಕ್ಕಳು ಎಷ್ಟೇ ತೊಂದರೆ ಆದ್ರೂ ತಡ್ಕೊಂಡು ಹೋಗ್ತಾರೆ, ಕಷ್ಟ ಬಂದ್ರೂ ತಮ್ಮ ಕೈಯಿಂದ ದುಡ್ಡು ಹಾಕಿ ಆದರೂ ಸಂಸಾರ ನೀಗಿಸ್ತಾರೆ. ಅಂಥ ಪವಿತ್ರವಾದ ಗುಣವುಳ್ಳ ಹೆಣ್ಣು ಮಕ್ಕಳು ನಮ್ಮ KCAನಲ್ಲಿ ಇರೋದ್ರಿಂದ ಇವರು ಮೂರೇ ಇಲ್ಲ, ಇಲ್ಲೆಲ್ಲ ಕೂತಿರೋ ಹೆಣ್ಣುಮಕ್ಕಳೆಲ್ಲ ಅದೇ ಜಾತಿಗೆ ಸೇರಿದವರು. ತುಂಬ ಅದ್ಭುತವಾಗಿ ಎಲ್ಲ ಸೇರಿ ಈ ಸಿಲ್ವರ್ ಜೂಬ್ಲಿನ ಅತಿ ಕಡಿಮೆ ಟೈಮಲ್ಲಿ ಮಾಡಿಕೊಟ್ಟಿದ್ದಾರೆ. ಆದ್ದರಿಂದ ಅವರೆಲ್ಲರಿಗೂ ನನ್ನ ನಮನಗಳು. ಅವರಿಗೆಲ್ಲರೂ ಮತ್ತೆ ಮನಪೂರ್ವಕವಾಗಿ ಆಶೀರ್ವಾದಿಸ್ತಾ ಇದ್ದೀನಿ ಅಂತ ಹೇಳಿ, ಈ ದಿನ ರಶ್ಮಿ ಅವರು ಒಂದು ರೆಸ್ಟ್ ತೊಗೊಳ್ಳಿ ಅಂತ ನಮ್ಮ ಅಶ್ವಿನಿ ತೊಗೊಂಡಿದ್ದಾರೆ. ವೀಣಾ ಅವರು ಹೆಚ್ಚಾಗಿ ಕೆಲಸ ಮಾಡಬೇಕು ಅಂತ ಹೇಳ್ತಾ ಇದ್ದೀವಿ. ಆದ್ದರಿಂದ ಇದ್ರ ಜೊತೆಗೆ ಇವರು PhDನೂ ಮಾಡಬೇಕು ಅಂತ ಹೇಳಿದ್ದೀವಿ. 2 ತೊಗೊಂಡು ನೀನು ಮಾಡಲೇಬೇಕಮ್ಮ. ಜೊತೆಗೆ ಮೀನಾಕ್ಷಿ ಪರ್ಮನೆಂಟಾಗಿ KCA ಆಫೀಸರಾಗಿ ಆಗಬೇಕು ಅಂತ ನಮ್ಮೆಲ್ಲರ ಆಸೆ. ನಿಮಗೂ ಇಷ್ಟ ಇರ್ಬೋದು. ಆಕೆ ರಾತ್ರಿ ಹಗಲು ಅನ್ನೋದೇ ದುಡಿಯುವಂಥ ವ್ಯಕ್ತಿ. ಆದ್ದರಿಂದ ಅಂಥವ್ರು ನಮಗೆ ಬೇಕಾಗುತ್ತೆ. ನಿಮ್ಮೆಲ್ಲರ ಸಹಾಯದಿಂದ ಈ KCA ಇನ್ನು ಮುನ್ನುಗ್ಗಿ ಎತ್ತರಕ್ಕೆ ಬೆಳಿಬೇಕು ಅಂತ ನನ್ನ ಆಸೆ. ನೀವೆಲ್ಲ ಸೇರಿ ಕೆಲಸ ಮಾಡಬೇಕಾಗುತ್ತೆ. KCA ಅಂದರೆ ನಂಬರ್ 1 ಇನ್ ದ ವರ್ಲ್ಡ್ ಅಂತ ಬರಬೇಕು, ಅದೇ ನನ್ನ ಆಸೆ. ಥ್ಯಾಂಕ್ ಯು ವೆರಿ ಮಚ್.
ಇಲ್ಲ, ಆಯ್ತು. ಮೆಡಲ್ ಕೊಟ್ಟ ತಕ್ಷಣ ವೋಟರ್
ನೀವು ಅಲ್ಲಿ ಹೋದ ತಕ್ಷಣ ಈಗ ಸಮ್ಮೇಳನದ ಮುಖ್ಯ ಘಟ್ಟ ಅಧಿಕಾರ ಹಸ್ತಾಂತರ ಕಾರ್ಯಕ್ರಮ. ಮಾನ್ಯ ಡಾಕ್ಟರ್ ಅಶ್ವಿನಿ ಮೇಡಮ್ ಅವರು ಡಾಕ್ಟರ್ ವೀಣಾ ಮೇಡಮ್ ಅವರಿಗೆ ತಮ್ಮ ಅಧ್ಯಕ್ಷ ಪದವಿಯನ್ನು ಅಧಿಕಾರ ಹಸ್ತಾಂತರ ಕಾರ್ಯಕ್ರಮ ನಡೀತಾ ಇದೆ. ಅಶ್ವಿನಿ ಮೇಡಮ್ ಅವರಂತೆಯೂ ವೀಣಾ ಮೇಡಮ್ ಅತ್ಯುತ್ತಮವಾದ ಅಧ್ಯಕ್ಷಣೆಯಾಗಿ ಕೆಲಸ ಮಾಡಲಿ ಅಂತ ಹಾರೈಸ್ತಾ, ಅವರ ಮೇಲೆ ನಮ್ಮ ಕಾಂತಾ ಮೇಡಮ್ ಅವರ ಆಶೀರ್ವಾದ ಸದಾ ಇರಲಿ ಅಂತ ಹೇಳ್ತಾ, ಈ 25ನೇ ಬೆಳ್ಳಿ ಹಬ್ಬದ ಸಮಾರೋಪ ಸಮಾರಂಭ ಎಲ್ಲರ ಕಾಂತಾ ಮೇಡಮ್ ಅವರ ಆಶಯದಂತೆ ಅತಿ ಸಂಭ್ರಮದಿಂದ ನೆರವೇರಿತು. ಅದಕ್ಕೆಲ್ಲ ಕಾರಣರಾದ ಎಲ್ಲರಿಗೂ ಮತ್ತೊಮ್ಮೆ ಅಭಿನಂದನೆಗಳನ್ನು ನಮನಗಳನ್ನು ಸಲ್ಲಿಸ್ತಾ, ಈ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಎಲ್ಲ ರೀತಿಯ ಸಹಾಯ ಸಹಕಾರ ನೀಡಿದ ಮತ್ತೊಮ್ಮೆ ಧನ್ಯವಾದಗಳನ್ನು ಅರ್ಪಿಸ್ತಾ, ನಮ್ಮ ಕರ್ನಾಟಕ ಅಂಗರಚನಾ ಶಾಸ್ತ್ರಜ್ಞರ ಒಕ್ಕೂಟದ ಪರವಾಗಿ ನಮ್ಮ ಅನಂತ ಧನ್ಯವಾದಗಳನ್ನು ಅರ್ಪಣೆ ಮಾಡ್ತಾ ಇದ್ದೀವಿ.
May I request Swapna and Sudha to come on to the dais and accept the token of gratitude for all the efforts and hard work.
Swapna Kanyadari, Assistant Professor of Physiology, who worked as a staff volunteer for our conference. And Ms. Sudha Patil, she is also staff volunteer from Department of Physiology. Yes, I request Kanta madam and Veena madam to hand over a token of gratitude to both of these staff volunteers. Dr. Suma MP madam is there? Yes, madam. Best paper in the category of oral presentation is given to Dr. Suma MP madam. And one more non-teaching staff, Mr. Guru. Manjunath, Guru, Shashidhar.
Last but not least, our KCA General Secretary ಅವರು ನಾ ಕನ್ನಡದಲ್ಲೂ ಮಾತಾಡ್ತೀನಿ ಇಂಗ್ಲೀಷಲ್ಲೂ ಮಾತಾಡ್ತೀನಿ. ಸೊ ಸರ್ ನಿಮಗೆ ಗೊತ್ತು, ಅವ್ರ ಪರಿಚಯ ಏನು ಹೇಳಬೇಕಾಗಿಲ್ಲ. ಸೊ ಅವರು ಎಲ್ಲರಿಗೂ ಕಾಂತಾ ಮೇಡಮ್ ಆಶೀರ್ವಾದ ಇರಲಿ ಅಂತ ಹೇಳಿದರು. ಸೊ ನಾವು ಏನು ಹೇಳ್ತಾ ಇದ್ದೀವಿ ಅಂದರೆ ಅವ್ರಿಗೆ ಕಾಂತಾ ಮೇಡಮ್ ಆಶೀರ್ವಾದ ಇರಲಿ. ಸೊ ಕಾಂತಾ ಮೇಡಮ್ ಅಂತ ಅವರು ಒಂದು ಟೋಕನ್ ಆಫ್ ಗ್ರ್ಯಾಟಿಟ್ಯೂಡ್ ತಗೊಳ್ಳಿ ಪ್ಲೀಸ್ ಸರ್.
Sir Reddy sir, from the beginning sir has been motivating all of us. Kindly accept the token of gratitude.
Sorry to interrupt. Just before national anthem, our volunteers want to speak just for 1 minute. They want to express their.
Good afternoon. We wanted to sincerely thank Veena ma'am and the Department of Anatomy for giving us the opportunity to volunteer for the 25th KCACON 2025. Your constant guidance and encouragement motivated us throughout the event. It was a valuable learning experience for all of us, and we are truly grateful for your trust and support. This helped us recognize our own capabilities. Thank you, ma'am, and thank you to the whole Department of Anatomy.
Let's all raise for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
I request everyone to join. I request everyone to join for lunch.